So we can switch again back to the cases to go on to discuss the cases. So this is part of an international congress. We have people live from and everybody's also busy with other things. So this case is done. Maybe the next case. Yeah. This is also a case from Frederick.
Yeah, so it's a guy, CEO of a large company. He's very healthy. He's 48 years old, and he had a surgical treatment of a ruptured Achilles tendon, but he didn't follow the post-operative recommendations. He went to Switzerland because he has a home there, and he had some parties, and he came back with some wound problems, and the wound problems got worse. So his wound is open, and you see the stitches, the non-resorbable stitches. What is your treatment strategy, and what are you going to tell this guy about his expectations? Because, of course, he wants to go back to work as soon as possible.
We have seen some problems from Switzerland already with wound problems.
So you can... But he's no comorbidities. He's a healthy guy, but... It's obvious that he has a...
What do you mean the wound is open? 1 centimeter, 2 centimeters?
Yeah, 1.5 centimeter.
Okay,
you can see the...
You can see the tendon.
It's already done. It's already done. You
No,
have to be aggressive, go in, take out the sutures.
Do you have an MRI?
Debride it.
You want an MRI?
I like MRI, sorry.
Yeah, but will it change?
No, for sure.
Will it change?
For debridement and then surgery and then...
What do you mean about a debridement? Would you remove the stitches?
100%.
Yeah.
100%.
I agree.
For me, I mean.
How would you remove the thick part of the tendon? You have some tissue fibers all over. So this is probably very much affected as well.
The problem is the skin is not closing above the tendon. This is...
It's not healthy tissue.
You can, with the rule that you can resect almost 50% of the tendon, and then you will have some skin to get. Yeah. But still, you must see the quality of the...
It's very bad.
The MRI is to see if you have infection all over distal and proximal.
You can see this...
Yes, but still...
Bacteria on an MRI?
No. You can see... I don't know...
Extent of fluid, extent of...
You can see the fluid in the clinical setting.
If you need to open a little bit more, or just... An open wound, you know what I mean?
Would anybody of you consider to do wound and arthroscopic addition? Some people do arthroscopic lavage in this case. Is this an option if you to get your point?
Yes,
if it's still open.
It doesn't matter. Yeah.
I think the most important thing is that what Nasef said, you should remove all the stitches.
Yes.
Because as long as you don't remove all stitches, the infection will extend to the patient.
But you have to go back to the operative room, so you will remove stitches.
But you should look that you removed everything. And probably you need to remove a big part of the Achilles tendon as well.
Yeah. And the other thing, remove almost 50%, and then sometimes you must leave it open, vac it and wait, and then close it in a secondary procedure, or just do it primarily. Try to close the wound, but that relies on the quantity of infection. If it's very bad tissue, you may not close primary. Just leave it open, vac it, cultures or whatever, and then wait and see what happens. But it's difficult to decide something sometimes to, I don't know, the quality of the tendon, how much tendon you need to take out, because you are in this 50% rule, so it's difficult. So and you may not do an FHL open at the same time. You may wait and see what happens with the cultures or whatever.
Yeah, you should clean first, clean up.
Wait. Maybe it's not a 2-period procedure, just not and close everything and then you're done.
So we did an aggressive debridement. We removed all stitches, but at the end we removed 10 centimeters of the Achilles tendon. Directly, because the quality of the tissue was not so good. We did vacuum-assisted therapy. We did not do a flap surgery. We discussed with the plastic surgeons. And we did wound care during several months, and at the end it got closed. And
What did you do with the defect at the end?
so it was covered by skin.
Okay, but you didn't do anything with the defect.
Because of in the wound healing, and the tissue underneath the skin, so the gap was filled up by fibrotic tissue, and at the end it got stronger and stronger, and now this guy is walking normally without limping. I had the idea to do an FHL transfer on a later stage, but it never happened because he didn't want to have any surgery anymore, and he's okay with his situation. He can work, he walks without any problem. I was surprised that the functions recovered so well, despite the fact that we removed such a large part of the tendon. And we didn't need to do any flap surgery, but this was a healthy person, so maybe other patients are different.
The flap surgery it's not comfortable. Also the therapy, also the afterwards. It's always swelling there, and functional is always not it's not the hope that we have. Yeah, good case. So we have time for another case. Could we get the next slide, please? Yeah.
So this is another case of mine. It's a male, 72 years old, but a lot of comorbidities, diabetes, obesity, balance problems. So this is one cannot walk without non-weight bearing, cannot walk with crutches, some minor vascular problems. Was referred by the general practitioner for a complete rupture of the Achilles tendon, confirmed by ultrasound, gap of 2 centimeters. And he has been walking around for 2 weeks with this problem. He noticed it not so much in the beginning. He limps a bit, but he can't really walk with crutches. So what treatment would you suggest?
When was the lesion?
2 weeks before.
2 weeks
So
before.
you see him the Friday afternoon, your last patient, and he's there. He asked your opinion.
So you can continue the functional treatment, and if after 2 months it's too bad, you can discuss a transfer.
Yeah, because it says he can really walk. So for me, you need to do something else, maybe directly a transfer. It's a good case. But for me, that sentence, he cannot walk. So he could walk with the transfer directly.
He limps a bit, but in this situation,
2
when he
weeks
comes to
after, it's
see,
normal to limp.
What?
2 weeks after rupture, it's normal to limp a bit.
Yes, but because he has rheumatism shoulder problems, that's why. So you have to rehab quickly.
Yeah.
The most quickly rehab by means by surgery would be FHL. I think so.
Endoscopic technique.
Yes. Endoscopic. Because the other techniques, maybe you cannot allow them weight bearing. It would be not safe, at least. This may be a case for endoscopic FHL directly.
Okay. What would you do?
I'm with Javier. This is a case, maybe we cannot call it surgery, it's more supported conservative treatment, something like this, because he will anyway end up with a boot, walking. So this 4-5 weeks we can support with this minimal invasive or endoscopic FHL transfer. This is, I think it's a risk and a benefit. It's good because he is in risk anyway of thrombosis and all those stuffs.
But what the risk to wait and to analyze the result 1 month later?
Yeah,
I agree with Guillaume.
But the rehab is the same time. Besides the surgery,
but
the
with
rehab
this
is the
surgery,
same time.
With this surgery, even if it's an arthroscopic transfer, you have some risk of infection first.
Still is surgery, but it's MIS.
Yeah.
It's quick.
MIS has complication,
Yeah, I know.
especially in this kind of patients with comorbidities, and after the surgery, he can't use crutches. So it will work just after the surgery. So the hematoma will increase, the edema will increase again,
I agree with Guillaume.
But, yeah, this is,
and probably the functional result will be good enough for this demand.
So I think if you would do we agreed we would not do a repair.
no,
Because there's-
repairs.
No.
A high risk. And then we have the advantage, if we consider an FHL transfer, that there is no problem with timing. You can do it 1 month later if you want.
Yeah, but then you have twice the rehab time.
Yes.
This is,
But
in
that's
this
why-
case,
that's why.
we have twice,
You're-
he's 72,
Yeah,
he's
you are
Your
right. This
rehab
is the
quicker.
positive point for the surgery, but you have the risk of the surgery and the risk of a bad result with the surgery because he has, it's a complex patient. Okay,
Cost benefit, I'd
FHL
rather
transfer
do it
has no
with FHL.
100% of success rate.
this is, yeah,
Yeah.
but
Guillaume, if he would come after 4 weeks or after 6 weeks walking with his total rupture, would you change your mind? Now he's at 2 weeks, so
Now, probably I will wait 3 months.
yeah.
And if he has still a functional
It's
complaint,
the same.
FHL transfer.
So if you go one way, you have to be on the path at least 3 or 4 months, not less.
but the question is, until how long after the rupture, so how chronic can be the rupture to still consider some conservative treatment and to expect some healing? After 2 weeks, I think,
No. 3 or 4 months, yeah, I agree.
Yeah,
until 3-4 months?
yeah, not less.
You are transforming an acute in a chronic,
Yes.
chronic.
If you go away, you have to give them a chance to
Exactly.
work.
And at 3 months,
If you want to start the treatment, if he comes to see you after 2 months after an acute rupture, would you still give it a try? Do you think still there is an opportunity to heal with a non-surgical treatment?
It depends also on the.
What do you mean with healing? It's functional gain.
Yes, I
gain,
would
it's
rather wait for the functional evaluation at 2 months because it won't happen anything in 1 month after. If it's functional, it doesn't work at 2
and you
months.
have to discuss with the patient. If it's an improvement period until at 3, if he still improve, you have to wait. And if at 3 he explain, okay, for the last month I have no improvement and I'm still a big problem for my day life.
Okay.
Okay, so let's go for the transfer.
So what would you consider the limit between acute rupture and a chronic rupture?
If you read the studies in the book, 6 weeks.
Yes,
But it's rather-
between 4 and 6 weeks.
It's a division. It's not really physiopathology
But
based.
in case of young patient, I think until 2 months you can try a direct repair. This was the first case. If you want to recreate the anatomy and to hope to have the best functional results, you can do it until 2 months.
So you say 2 months for direct repair?
Yeah.
If you do MIS, what is your limit?
MIS what?
MIS reconstruction.
child, probably.
Not open, so would you do MIS reconstruction up to 2 months? After I could rupture?
What do you call a MIS reconstruction?
I do the Dresdner.
Dresden.
The Dresdner.
Okay, no.
Percutaneously.
Yes.
Percutaneously.
Yes, I think after 3 or 4 weeks, you can't do it percutaneously because you have to remove the fibrosis tissue to confirm the quality of the tissue. And
So 2 months for open and
yes,
for
1
MIS.
month, 1 month for percutaneous, 2 months for open,
Yeah.
and then we have to consider palliative treatment.
I think 1 month is also a little bit.
Yeah, sure. It's
This is-
probably 3 or.
Yeah.
What did you do?
What you did?
I did a course during 2 weeks and then a functional treatment with a boot.
And so?
And he went well. He was happy.
Yeah.
Yeah.
Okay.
This is
It's typically a functional case. So we have to discuss with the patient. If a patient is 54 years old, like the previous case, and he has a high demand, we have to try the repair, I think. If his demand is not so high, you can go to the transfer.
So the activity level and the comorbidities are very important, not
Sure.
only the age.
Sure.
And you discuss with the patient.
Functional treatment, sorry?
No, but we all agree that the FHL the rehab will be faster. Even the functional will be the fastest for these patients. Then you have the comorbidities and the.
But some patients don't want to be fast. They want to avoid surgery.
Yes, but he can really work with crutches.
And other patients want to have the best functional result. And in my opinion, a direct repair is the best option to have best functional result than a fascial transfer.
So we have 5 minutes still to the next talk. I would stay a little bit to this case. Do you, the FHL transfer, we talked about this. Do you see any benefit? Is it faster in the rehab than the conservative? Is it faster?
For me,
we
yes.
know it's stronger, but is it faster?
For me, yes.
It's faster.
You can go faster.
Yeah,
Sure.
Compared to
conservative.
Functional, not conservative at the end. You can go faster.
I think so, but I don't think it's the same.
Not really faster because it's.
Yeah, it depends on the population.
Yes, because you practice a fascial transfer for more demanding patient.
Yeah.
Again, yes, we cannot compare.
Yes,
It's
difficult. Yeah, the population is different.
Yeah, and functional is so different. But what is functional? It's just full weight bearing. And as I mentioned, I'm using this boot to allow plantar flexion. So this gives me more power.
In some patients, it's difficult to activate them to go to the physiotherapist to mobilize. So functional treatment in one patient will be different in the other. Even if you give the same protocol, some of them, they have difficulties to put on and to remove their boot, and they need some help for these things. So these are also things we need to take into consideration.
But once again, the advantage of the fascial transfer, you could do this later. So it's not a problem if you have a failure with a functional treatment or with a conservative treatment.
I agree, but still you tried.
Yes,
you tried one treatment
time,
and then yes.
But it's still an option,
Yes.
and a very good option.
Yeah. Good. We are perfect in time, so we can go to Nasef, and he missed the FHL talk. He is our FHL. He's the most, I think he is really experienced with FHL transfer, and he published a lot of papers, and his talk will also be about FHL. So we give the panel to Nasef Mohamed from Egypt, and he's taking care of the Egypt, and also we have South Africa with him in the session. So Nasef, can you hear us? It's yours. It's your panel.
So, hello everyone. It's a great honor and pleasure to be here. I hope everyone here is learning as much as I am. I'm Nasef, Mohamed Nasef. I'm here with my good friends, Dr. Ossama El Shazly and Dr. Maritz. We're representing Africa, the Middle East, and specifically, of course, Egypt. So I will start off with my talk. So I'm here to talk about a rather controversial subject. It's FHL transfer, endoscopic specifically, for acute Achilles ruptures. Is it a fact or is it a myth? These are my disclosures. I'm sorry I have to put them up, but they don't have any relevance particularly to this talk. So we know that the ruptures we've heard anatomy and biomechanics much more better than I can say, but we know that there probably will be a pre-existing degeneration. It's more in men, it's usually within the 30 to 40 years old, and in more than 2/3 of the patients, these patients are actively in sports. So there will be a pre-existing injury. We know about the medications, and we know that it also affects sprinters more than it affects long-distance runners. And that should also be part of our algorithm when we're thinking about how to treat them. We do know it's the most common tendon rupture, and it also has rupture, but also degeneration. And it's increasing. I took this from my good friend Bruno from Portugal, and you can see that muscle tendon really rupture, as you can see. Our goal, whatever it is we want to do surgery, is to restore tendon integrity, length, and this is very important, and of course the function to allow to a return to full pre-injury level of activities. Now, we know that from histology, there are 3 phases of repair. We know the inflammatory, the proliferative changing, but this is the most most important, I think the modeling stage, it happens after 6 weeks, so almost 4 to 6 weeks. And it happens according to the direction of load applied. For me, I think this is the most important, because if you do a good repair, but you don't load the tendon, you probably won't get off with a very good result. Now, we know that conservative treatment, functional conservative treatment, it works. But even if you ask the most professional conservative functional therapy, they will tell you that 9 months is when they would gradually return to their high impact. And I think even for normal people, that's a lot of time. And so the definitive treatment for acute Achilles ruptures is still very controversial. We're still here, we're in 2025, but we still don't know what is the main method of treatment. We do know that authors are reporting satisfactory results with whatever method they're using, and especially, of course, minimally invasive. And if you are thinking about doing surgical treatment, you'd probably be thinking about doing it minimally invasive. And endoscopically, people tried to repair directly the tendon, and this is where it was very cumbersome. It required a very high learning curve, and the results were not so great, so people started resorting, no, let's go back to open and doing it or percutaneous. And this is where we thought the group I am very proud to be with, Jorge Batista, Del Vecchio, and Pereira, we thought about doing it in acute cases. It worked so well for chronic, and so we thought about doing it for the acute. We took our good ethical approval of the patients and of our institutions, and we went ahead and decided to perform the endoscopic FHL transfer for acute tendons. And we published this almost 4 years ago. And this is just, you've heard so much about the technique, but just a quick video to show it. I do drape the contralateral limb. I use it as a reference, and I'll show you why. We have discussed that the FHL tendon, you need to identify it. It's basically easy, but then you need to really proximally release the tendon. And then, of course, with the ankle in maximum plantar flexion and big toe, you can use a beaver blade, you can use an 11 blade. This video was taken in 2016, so I used the shaver blades. Then I do an endoscopic calcaneoplasty. This is important for me. I use a third central portal because it's much easier, and I place the Achilles tendon, the FHL tendon, exactly at the position of the insertion of the Achilles. I do not touch the Achilles. I make sure I have a blind and a tunnel, and in our studies we found that you only need 3 centimeters. And then I take out the FHL tendon, and I place it with a nitinol wire inside the tunnel, as you can see there. And then I place the, now this for me is important. People are individualized. I do not believe Achilles tendon are the same. I individually tension it according to the contralateral normal side. I hold the tension, and then I place the screw in that direction, in the direction of that tension. So it's kind of an individualized FHL transfer for each individual patient. Usually the tendon is is less than 7, and so you usually need a 7 screw. Now, at the end, you can do the test on the table. As you can see, I have both feet up, and this is the end result. You can see only those 3 incisions. And we start, and I think this is very important, we start from neutral. We don't go to plantar flexion because you have already created a biological and a mechanical strut. And then you can go along with your rehabilitation accelerated as you want. So we were so excited with our results that we decided to consent also professional soccer players. I'm fortunate enough to also treat soccer players, and I teamed up with Jorge Batista, who also manages the Boca Juniors team in Argentina, and we decided to do this on professional soccer. So these are high-grade people. These are really high-level performance athletes. And if we looked at our results, we found that the plantar flexion power, the contralateral side, was almost acceptable. There was no significant discrepancies. But what was very important was that the return to training and return to play. Now, these are 2 different entities. You can return to training, but you still don't have the confidence, and those that have the Achilles injury will tell you that, the confidence to play. And what we did look at also was the number of seasons that the patients, the players, were able to play at the same level. This is important. They were not relegated to lesser divisions or to lesser teams, if you will. And the MRIs are always very striking. We would do a preoperative MRI, of course, for the diagnosis. Our first week post-op was to make sure that our tendon is back where it should be, our screw is exactly where it should be, and then this is the 18-month, and we can discuss, of course, the level of the homogeneity of the tendon and the FHL, but we do know that it hypertrophies, and it does give the patients good results. Now, we also went back and we looked at, okay, so is this as good as the percutaneous? This for us was what was standardly being used, and most of our results were comparable. And you have to have good outcome measures. We use primary outcome measures, of course, the ATRS scoring system. Most other studies were using the AOFAS, Tegner activity scores, so that is also very important. And we did this for a very large follow-up period at a mean of 42 months. Now, secondary, and this is very important because we wanted to check, are we reducing the power that we are taking the tendon off? So we did an FHL dynamometry and we did an ankle plantar flexion power, and both of them, and of course, more importantly, we looked at the Achilles tendon resting angle. We did that preoperatively, intraoperatively, and postoperatively at their follow-up visits. And actually, we use that to gauge when we can accelerate the patients during their rehab, the ATRA. And the complications, they were almost comparable between the PARS or in the FHL transfer cases. The activity level, and this is important, was also equal. Now, we know that ever since 1999, people have been using the FHL. It's a strong muscle. It has the same line of pull. It's also in phase, and I think this is very important during the gait. But it's also muscular till the ankle, and it can hypertrophy. And I think we can use those benefits for the FHL transfer. Now, what are the advantages? You're taking a biological source of healing. You're doing a mechanical strut, allowing for an uninterrupted, safe Achilles healing, as if you're treating them functionally conservatively. And these healing tendons do hypertrophy. But also, you're doing a functional physiotherapy that is starting very safely and more aggressively from the start, from neutral. And I think this makes a huge difference as opposed to all the other techniques. We believe that the ATRA is individual. We had a wide degree of standard deviation of patients' resting angle. These two patients are different, but look at their resting angle. They're different completely. I don't think that we can tension them both the same way. The Achilles is then allowed to be stressed from neutral, so we avoid the plantar flexion and possibly the ankle stiffness. And of course, the Achilles paratendon and the surroundings are untouched, and I think this allows for a more biological healing environment. Now, the Achilles tendon resting angle has been shown to be directly related to strength and muscle power. Now, this is a patient that had an FHL transfer, and look at his gastrocnemius soleus component. It's really huge. Yes, he was a professional football player, but this is his calf muscle after the operation. And of course, you have almost no skin problems and very good cosmesis. So, if you want to get better, we have to listen to our critics. So what is the most important critic? Is that, of course, there is a loss of plantar flexion of the distal interphalangeal joint of the big toe. But I think this was masked by the history. They used to do open incisions. They used to take it from a second incision from the plantar surface. And even in those studies, you would find that they would say, well, the plantar flexion power was not that much affected. This was when they were doing it 2 incisions and from the sole of the foot. And even for chronic Achilles, you would find that after 6 years of follow-up, still the patients did not have that much of a compromise in their plantar flexion power. Of course, this is probably due to the knot of Henry, and we'll come to that in a while. So even when you measure the peak pressures, so this is objective measurement of peak pressures of patients that have taken their FHL, whether it's for chronic or acute injuries, and you will find that they're comparable according to their foot peak pressure studies. And of course, we do know that the transferred Achilles, the transferred FHL tendon, and the Achilles both hypertrophy, and this can be seen interestingly on the MRI. This hypertrophy is almost 50% of the normal tendon, so that gives you a good amount of biology and a good amount of mechanical strut. And I think this is important. Also, our knots of Henry are different. If you go to anatomical studies, you will find that there are people that have very high intertendinous connections, but others, the type 4, that have no connection whatsoever. And I think this is important. So what about the rest of the criticism? Well, we are the only ones performing it. No, we are not. There are groups in Greece, and even we have our star speaker in a while, Nicola Maffulli. He is starting doing his percutaneous technique, but also adding an FHL to it because he wanted to improve his functional outcome. And even Jesus Villa in Spain, they started doing it for distal traumatic ruptures, FHL, endoscopic transfer for acute distal traumatic ruptures. Very interesting. So if we look at what we have already, are our currently used methods, are they enough? Systematic reviews show, especially for athletes, no. A lot of these patients, probably maybe 25% of them, they will never return back to their activity level. So we have a tendon that we need to try, there is space for improvement, maybe not by methodologies that are common, but maybe we need to improve it. So who would I think about doing my FHL transfer for? Definitely diabetics. Those people I don't want to open or even treat conservatively. Obese patients, those that will not be compliant with their functional rehabilitation. And of course, those that have skin burns or scarred skin. And I have a few patients of these that had these injuries, but they also sustained Achilles injuries. And of course, if you deal with professional footballers, some of them will tell you, doctor, do anything, but don't ever touch my tattoo. It's my good luck charm. And okay, who would I not do my FHL on? If you look at the patient and they can independently flex their big toe without motion of their interdigital other toe motion, then these patients have independent FHL motion. They are solely dependent on that FHL. I would be very reluctant to take those FHLs and transfer them. And of course, if they refuse the procedure after a good consultation with them, and of course, if you don't have good surgical experience, especially with the endoscopic technique. Now, this is a video of a player. He's the one in the right. This is 5 months after his FHL transfer, and he's performing first division. Of course, if I showed you an Egyptian player, it won't be as convincing as a Boca Juniors one, I guess. But anyway, this was one of our patients. And these are a group of patients. It's a very busy slide, but the only thing that is in common with these patients is that they were all filmed at 4 to 5 months post their FHL transfer. So I think it's something we need to keep in our armamentarium. So to take to work, FHL is a low-lying muscle. It has the same direction of pull. It fires during the same gait. It's strong. It's anatomically there. It has good vasculature. Arthroscopic technique is perfect. You can overcome your skin and healing problems. It might provide at least as good results as conservative or surgical treatment, and it has been established for chronic cases. So maybe the dilemma is, okay, would I use it for acute? It can be used even in high-level demanding athletes. It does not leave significant defects in the flexor strength, and this is by objective tests to the non-operative side. But of course, we need further randomizations. Of course, I'm a very proud Egyptian, and I can't leave you without this last slide. We are very famous, of course, for a lot of stuff, but especially the hieroglyphics. If you all know, this is the eye of Ra. It's also called the Wadjet. And 4,500 years ago, the ancient Egyptians, the pharaohs, used this symbol for the 6 senses that we now understand. So it's the smell, as you can see there, the sight, the hearing, the taste, and the touch. And we also had a left eye and a right eye. Now, the right eye is the masculine one, and it gives a symbol of good luck. But the left eye is feminine, it's moon, but it was a symbol of healing powers and protection. And this is what has transferred into what we doctors write on our prescription notes every day. Thank you very much for your attention.
So, Ossama, great to have you with us.
So I will just talk about management of infected Achilles repair. We have heard a lot about many invasive surgeries, and we have just enjoyed the presentation of Dr. Nasef about how to make arthroscopic flexor hallucis longus tendon transfer. But by all means, when we have such problem, it's really a serious problem, infected Achilles tendon. It's a nightmare and a catastrophe. So I declare that I have no conflict of interest. As the intended learning outcome of my presentation is to identify the causes, magnitude of problem, outline treatment options, and show the results of our unpublished study about management of such infected Achilles tendon. Let's say it's a potentially devastating complication when we have infected Achilles tendon. One complications following repair occur in approximately 7% to 13% of cases, according to literature, and deep infection may reach up to 2 to 4% with open treatment. This is why minimally invasive techniques and arthroscopic techniques may overcome this problem of infections. When we have infected Achilles tendon, of course, we have delayed recovery after repair, loss of Achilles tendon during debridement, so we lose part of the Achilles tendon, loss of soft tissue coverage and skin, which may necessitate sometimes skin grafting or using flaps. Some risk factors associated with infection of Achilles tendon, including smoking or tobacco use, steroid use, female sex have higher incidence according to literature, diabetic patients, open Achilles injury, allografts, and non-absorbable sutures, especially some cases who have nylon tape, artificial tape, like this case which we are seeing right now. When we treat a case of infected Achilles tendon, we have certain goals to achieve. One of these goals is to eradicate the infection, and the other is to restore the function of Achilles tendon. And this can be achieved through single or multiple stages. When we make debridement, one of the challenges is the incision. How will we plan our incision? Should we go through the previous incision, or we go through the sinus in order to incorporate it inside our incision? And if the patient has graft, how would you plan our incision away from the graft site so not to vascularize this graft? When we make debridement, we aim to take culture of the organism, also to debride all necrotic tissue which is in the field of infection. And we have to remove all retained sutures. And of course, non-absorbable suture is one of the common causes of such infection diseases. Or should we rethink again about using of kind of sutures of repair of tendon Achilles? Because I find a lot of these non-absorbable sutures one of the causes, and recently I shifted to more absorbable or delayed absorbable sutures in repair. Also, removal of any retained materials, and such case had infection of Achilles. We did a lot of debridements, and all of a sudden, after a while, we found these foreign body under the skin, and it was part of the biodegradable screw, which was not absorbed, and it come out with infection. It was under the skin, like you see here, and this was strange. When we make histopathology for it, it was a biodegradable plastic screw. Also, removal of anchors when there is insertional rupture, it's a little bit a challenging problem, especially when it is deep-seated in some cases, like such case, which we could see here, infection around the anchor, and it's deeply seated inside the calcaneus. So removal needs some help of image intensifier and some tricks to remove it. Local antibiotics or cement-load spacer can be used after the first stage if we make extensive debridement, and after that we can make vacuum therapy until soft tissue healing if we have a small gap, or we can make skin coverage if it is possible, and skin flap if it is not possible to do skin coverage. To restore tendon function, we need to make after debridement of the Achilles tendon, we need to make either preservation of the initial Achilles tendon using any other technique like direct repairs or VY or any kind of techniques which preserve the original tendon Achilles. And this is, of course, limited to cases where there is mild infection, and during the time of initial debridement, we don't remove too much of the tendon. So in this case, we can preserve the original Achilles tendon. But in most of cases, we will need to make a radical debridement and removal of huge part of tendon which is not reconstructable, and in this case we need to use tendon transfer, for example flexor hallucis longus tendon transfer, in order to replace the removed Achilles tendon. I will show two cases. The first case is a case treated with preservative debridement procedure for a 22 years old male. He is practicing football as a hobby, but he is not a professional football player, and he got infection after repair, no response to antibiotic therapy, and MRI, as you see here, shows localization of infection, and there is an abscess around the Achilles tendon. And debridement was done with preservation of the as much as we can of the tendon Achilles. We removed the stitches, we removed necrotic tissue, we used irrigation with hydrogen peroxide and using irrigation with antiseptic solutions. And finally, after we finished this debridement, we added loaded sheet of antibiotic inside the wound, and we stayed until the patient was healed. And the scar here, it's a little bit ugly scar, but it was covered without any skin graft and without flap, and the patient was functioning well. I could make tiptoeing, and he has good tension of the tendon, so we didn't make for him flexor hallucis longus tendon transfer, and we relied on the remaining part of the Achilles tendon. Surprisingly, with follow-up MRI, we can find the tendon Achilles is nicely healed, like in this case 3 months post-operatively, compared to the pre-operative status of the tendon with infection. Another case which shows two-stage procedure treatment for a lady. She is a little bit older, 52 years old, Morocco lady, and she got insertional Achilles rupture, avulsion, and she had originally calcifications of the tendon, and she was treated with such technique, with repair, removal of the calcifications, and repair using two anchors. But unfortunately, the patient got infection and she didn't respond to antibiotic therapy, and she underwent preservative debridement in Austria, where she received her initial treatment, and the initial debridement improved the situation a little bit. But later, after 3 months, the patient came again with collection, severe tendon affection, and MRI shows degeneration of the tendon, and shows as well there is too much fluid collection and abscess collection inside. So we decided to make here the two-stage procedure. First stage is debridement, removal of pus, and removal of all retained sutures, and then debridement, extensive debridement of the whole tendon, and then we put the antibiotic loaded sheets inside, and after that we made closure, and we followed up the patient with antibiotics, and she can start with pairing in using PUT, and until the white blood cell count, ESR, CRP returned to normal. And then we went to the second stage when we made open FHL transfer. Of course, we can go for arthroscopic, but I was afraid to do arthroscopic technique with the adhesions after the initial debridement, but of course it's still viable. We can do it arthroscopically, and I usually use biodegradable screws. Sometimes I add extra cutaneous fixation with put-on fixation to the Achilles tendon. And this is a follow-up of the patient. She has good tension of tendon Achilles and good power of the tendon Achilles, and she can walk and satisfied. And this is a follow-up MRI after resection of tendon and relying only on the FHL. Our study is still unpublished. We carried out retrospective study with prospective analysis of data from 2019 to 2024. Total number of patients is 14, mean age is 55, and the male patients were 11, female patients 3. 4 patients were diabetic, rheumatoid arthritis within 1 patient, 7 patients were active smokers, and prior Achilles steroid injection was in 2 patients, and follow-up of patients was around 21 months. We needed only primary closure in 4 patients with single debridement status, I showed one of the cases. 2 debridements were done for 3 patients with primary closure of skin. Vacuum-assisted wound closure was needed for 3 patients for a small gap which was found and which was healed nicely after. Split thickness skin grafted needed for 1 patient. Local tissue flap coverage was needed for 1 patient. The tendon preservation was done for 5 cases, but FHL transfer in most of the cases was needed because of extensive debridement of the tendon. The organisms which we encountered, staph in 5 cases, no growth in 4 cases, Pseudomonas in 3 cases, staph epidemis for 3 cases. The functional outscore, foot and ankle ability measure activity of daily living score, was mean of 87.2%. The subgroups normal 3, near normal for 9 patients, and subnormal for 5 patients. Of course, in this study, none of our patients were professional athletes, and the outcome is different if regarding their practice. Anyhow, stating also 14 patients, we have only limited number of cases. So in conclusion, Achilles tendon infection, serious complication, radical debridement should be done, removal of any tissue and retain sutures for any foreign. 2-stage procedure is safe. Transfer is good viable option. Reconstruction, plastic coverage should be considered in all cases. Thank you so much. Thank you so much. Thank you so much. Thank you so much.
Ossama, thank you very much for your talk. Wonderful as usual. Thank you very much. It's a great pleasure to have you with us. I know you're in between airports. Will you be able to stay till the end after Mark Maritz's? Because I'm sure we'd like to ask you a few questions. Or would you like we ask you now? Ossama, you're muted. You're muted. We can't hear you.
Okay, if possible, I can receive my questions now. If possible, I can receive my questions now. If possible, I can receive my questions now.
Okay, Frederick?
Just a short question. So you said non-resorbable sutures have a high risk for irritation and infection. So which wire would you recommend to repair Achilles tendon?
Usually use nowadays monofilament sutures, like delayed absorbable BGS sutures. I prefer BGS sutures, delayed absorbable sutures, because I found, especially with iffy bond, the risk is higher. Or fiber wire, if you need non-absorbable suture, which is safer. But graded iffy bond sutures carry risk of infection. I hear an echo, so I don't know if you hear me well or not.
Yes, we heard you, but if you want, muted the Teams.
The Teams call.
The Teams call. And now we can't, okay. Now we can't hear you, Ossama. We can't hear you, Ossama.
But when I muted, I cannot hear you. But when I muted, I cannot
hear you. We appreciate you taking in between your comments. Thank you very much. And thank you for being live. Thank you.
Thank you. Thank you.
Now it's a great honor and pleasure also to introduce Mark Maritz from South Africa. He's a very good friend of mine, and he's here to talk about minimally invasive Zadek for insertional Achilles tendinitis and Haglund. Mark, great to see you.
Hi, Nasef. Hi, thanks. Can you all hear me?
Yep.
Yeah.
Perfect.
And you can see my slides, can you?
Not yet.
Yeah.
Wow.
Yeah.
Perfect. And also presentation mode, so that's perfect.
You got it.
Perfect.
Right.
Floor is yours.
Right, thank you. Yeah, I'm presenting live from my hometown, Cape Town in South Africa, and it's a great privilege to be able to present on something that's quite topical at the moment. and that's the Zadek osteotomy for treatment of insertional Achilles tendinopathies and a Haglunds syndrome. So just to recap, what are we talking about with Haglunds syndrome? This is a triad of an insertional Achilles tendinopathy with a retrocalcaneal bursitis and a prominent posterior calcaneal prominence, or a Haglunds bump. And these are difficult patients to manage, I think. A lot of them have got quite significant morbidity from this. It's a painful condition, and it's been quite difficult to treat in the past. So why the Zadek osteotomy? So in my practice, it's been a bit of an evolution. It's taken me several years to get to the Zadek option, and I've chosen the Zadek route, to be honest, just because of a lack of a better alternative. So I started out with the open debridement and Achilles detachment, which I think many people do. And this procedure, although it alleviates the patient's symptoms in time, and that's backed up with evidence, that there's an incredibly long healing time for these patients. And I think 7 months is optimistic. I would tell patients at least 12 months before back to activity. But the biggest concern, and especially looking at Ossama's talk, is the damage to soft tissue. And you only need one deep infection in this area to make you think twice about this procedure. So I aborted this several years ago, and I migrated through to the endoscopic calcaneoplasty, which was quite attractive for me. It was being arthroscopic. I didn't have to worry about the soft tissue envelope, and patients did well. If you did well with a calcaneoplasty, these patients were quite happy. The problem, though, was you often found certain patients that didn't do well, and you can't predict who's going to do well and who's not going to do well, and you could often not find a reason why they weren't doing well. So there was this variability in outcomes, and there was a recurrence rate that varied, and again, literature backs that up. So a good procedure, but there were problems, and something else was needed. And I think this is where the Zadek osteotomy comes into play. So the Zadek gives very predictable outcomes. You afforded a nice early recovery with them. You can do your Zadek as a minimally invasive option, and relatively few complications. Now, it's not a new procedure. Zadek is something that was first described in the 1940s. And for those that don't know, it's a dorsal closing wedge osteotomy of the calcaneus. Now, does it work? Well, a Zadek osteotomy has been a complete game changer in my practice. So these patients are, and I think anyone doing Zadeks will attest to this, that the patients do very well very quickly. They, in fact, at 2 weeks follow-up, they will tell you that their previous retrocalcaneal pain is completely gone. They are very happy, and the literature is backing it up. I think Oliver Schipper is probably publishing the most on Zadeks at the moment, and with really good papers showing marked improvement of their outcome measures with a rapid recovery, and importantly, a really low complication rate. And the complications that one gets are quite minor. So I think that's quite important. So how does this osteotomy work? So we're doing a dorsal closing wedge, and essentially what happens is that the posterior prominence shifts anteriorly, and biomechanical studies have shown that this decompresses the retrocalcaneal space. It is changing the lever arm of the Achilles tendon, so you are gaining an increased range of motion in the ankle. And it's also been shown that there's strain changes in the Achilles fibers. So it's presumed that all these changes are what is giving the benefits of symptom relief to these patients. What about the mechanics? So there's this concern that we're gaining range of motion. Are we not weakening the posterior chain or the calf muscles? And that was a real concern, I think. But I think it was more of an academic concern because when you see these patients in the long term, 6 months, a year down the line, you don't perceive any weakness in plantar flexion. And that's just now been backed up with some further biomechanical studies to show that there's no difference in the plantar flexion strength between pre-op and post-op. But what you do see is quite a marked improvement of gait mechanics. And that's because they have an increase in the propulsive impulse. There's an increase in their step length. So these patients walk so much better post Zadek than they did before. So who should we be doing Zadek osteotomies on? Well, obviously the insertional tendinopathies, but this is a bit controversial. There are no hard guidelines of who should be getting a Zadek. Tournay, he did a great study looking at the XY ratio and said that anyone below 2.5 would benefit from a Zadek. But recently, again, Oliver Schipper and his team have showed that, well, regardless of the XY ratio, these patients do well. So in my practice, I ignore the XY ratio. It's not something I look at. A Zadek is my first line of treatment for insertional problems, especially if there's an element of retrocalcaneal bursitis or any kind of bony change with an insertional spur. I'm going to go straight for a Zadek. So I disregard the XY ratio, but I suppose more work needs to be done on trying to identify who we should be doing Zadeks on. So what do I want to achieve when I'm doing Haglunds surgery? So first of all, definitely I want to do a Zadek. And then there's these additional procedures which are a bit controversial perhaps, removing the posterior prominence, further debriding the bursa and removing the spur. So just having a look at some of those technical aspects. The osteotomy, this I do with a minimally invasive technique. So this is a lateral approach. I use a 3mm Shannon burr, and I'm not taking out a wedge. I'm doing straight lines and doing more of a kerfing maneuver just to remove the bone until I feel I've taken sufficient bone out. Now, importantly, the vertex of that osteotomy, you need to try and place that as close to that plantar fascia insertion as possible, and I'll show you why later. The base on the dorsal side, you can move that more posteriorly and incorporate that Haglunds bump. I don't do that. I find that technically a little bit challenging, so I move it a bit forward, as you see in this picture. But closing down the osteotomy it's quite rewarding to see it close down. All you've got to do is dorsiflex the ankle, and immediately you notice the increase in the range of motion, and you see how nicely that osteotomy closes down. Obviously, you need to make sure you don't break that plantar hinge. You need to try and keep that intact. So what about that insertional spur? And this can get quite big in certain patients. Now that's been shown that you can leave that alone after your Zadek. You don't need to remove that. I remove it. And the reason for that is twofold. I don't want to get a pressure point in a shoe. The patient's wearing a shoe post-op. There's nothing worse than having to go back and remove it if they've got pain. So I remove it. But it's also quite easy to remove with a minimally invasive technique. It's quick, it's simple. The concern is always, people always ask, well, what about you detaching the Achilles tendon fibers? And sure, you are, but no more than 15%, I would say. That spur doesn't originate on the whole surface area of the back of the Achilles and of the calcaneus. And the Achilles attachment point on the posterior calcaneus is huge. So yes, you're detaching a few fibers, but I've never had a calcaneus, or I've never had an Achilles detachment, and I've never seen the need to reinforce or put extra anchors in to strengthen the Achilles attachment. I know the industry has now developed some of these minimally invasive little anchors for this. I don't see the need for it, to be brutally honest. So what about the retrocalcaneal space? Do we need to further decompress this after after the Zadek? And the answer again is probably no. You probably don't have to, and purists probably wouldn't. But I do. I like to remove that posterior bump, and I do that with a minimally invasive burr, as it's quite quick and easy. But I like to do an endoscopic calcaneoplasty. I want to debride that synovitis that's in the retrocalcaneal space. And there's usually a significant synovitis there. I think that contributes to their pain. So by removing that, I think you expedite their recovery, you expedite the time that they get resolution of symptoms. So it is something I do, but it's probably not always necessary. What is a concern, though, is the effect that a Zadek has on the plantar fascia. So as you rotate your posterior fragment, you're going to be over-tightening your plantar fascia. So there have been reports of patients developing plantar fascia-like symptoms post-operatively, and I think it's prudent to let your patients know that this may occur. It's quite seldom. It doesn't happen very often, and if it does happen, it seems to be self-limiting. So it doesn't concern me that much. I think a lot of those patients resolve with plantar fascia massage. That when I am concerned is if I see a large calcaneal spur such as this. So you can see that by rotating your fragment, that spur is going to become more prominent and might cause further impingement. So I just go in with an MIS burr and I just remove that before the start of the procedure. What about the tendinopathy that we see there? And sometimes on an MRI scan, it's quite significant. I ignore this completely. This doesn't concern me at all. I don't do a debridement. I don't do an FHL transfer. It heals. Clinically, I don't have any MRIs later on to check that, but you can feel clinically it certainly gets better. And I think that's a combination from the Zadek detensioning the Achilles, but also by removing the posterior bump, you're exposing all the bone marrow to the tendon, and it's full of stem cells. So I think it gets better from that point of view, but the tendinopathy doesn't concern me, and to the point where I no longer take MRI scans because I think the MRI scan overestimates the severity of the tendinopathy and everybody gets anxious. So recovery is quick. They're in a back slab for about a week. I get them moving full active range of motions within a week, and I try and get them full weight bearing at 2 to 3 weeks. I do keep them in a boot for about 6 weeks and then come out. But you can see a 6-week post-op x-ray, you've got almost full consolidation of that osteotomy site. So it heals quite quickly. So to close, the Zadek has certainly been a game changer in my practice. It's safe, it's effective. You have high patient satisfaction rates and technically quite easy if you've had the right MIS training. So I think it's something that hopefully is going to gain more traction as more studies come out, and I think we'll be getting better outcomes with our patients. Thank you.
Thank you very much, Mark. Awesome as usual, yeah. So I have a question. I noticed you said that you have, you kind of disregard your XY ratio on the calcaneus, right?
That's right.
Yeah. Would the calcaneal pitch angle play a role in your being more decisive to do a Haglund rather than not?
Yeah, so the pitch angle has been shown to be, along with the XY ratio, a factor when looking at a Haglunds syndrome. If you have a high calcaneal pitch, you can correct that slightly by changing where you place the vertex of your osteotomy. So you can posteriorize that vertex slightly, and it will change the pitch. But I don't, to be honest, I don't really look at it that much. If they've got symptoms of insertional tendinopathy, whether they've got a high pitch or not, I'm going to do a Haglunds, but it's just about where I'm going to place that vertex. I'm going to probably go a bit more posterior if the pitch is high. Yeah.
So you would disregard the degree of Achilles involvement. You would disregard if they have a Haglunds or not. And you would not really consider much for a. So I get the feeling that the Zadek is now your go-to for any case of insertional Achilles.
That's right, yeah. So the one scenario where I wouldn't do it are the very early insertional tendinopathies, where you do an MRI scan perhaps and you would just see some bone edema, but there's no retrocalcaneal bursitis, there's no insertional spur. I think those patients do well. Well, they do well conservatively, but if they don't respond, I would rather then do a proximal gastroc recession on them. I think a Zadek is probably too much there. But the minute there's bony changes or calcification at the insertion, I feel that a gastroc release is not sufficient. You need to change some mechanics here, and I'll go straight for a Zadek.
I think it's interesting that you would consider a lengthening in cases with only some minor inflammation. Another thing, if you have a Zadek with remaining complaints, for example, they come for a second you have a backup plan. I think you will not do a reverse Zadek and not reverse this procedure. How would you address these patients?
Okay, sorry. So if I understand the question correctly, is what would you do with patients with residual symptoms of post-Zadek? Is that right?
Yes.
Okay, so interesting. I haven't had that. The symptoms that I've had after a Zadek have been different symptoms, like plantar fasciitis. But to date, I haven't had a Zadek osteotomy that had persistent insertional problems. And I think that's the power of the surgery. If they did, and you can never say never, and I'm sure it's going to happen next week. I'm going to get someone come back. But if they did, I don't think you can do a reverse Zadek. Then you need to go and possibly looking at doing an open debridement, maybe an FHL transfer. I haven't had that situation though. What I have seen though are patients where they've had an open debridement and they've got persistent symptoms, and then the question is, should we do a Zadek on those patients? And unfortunately, and I've done that, but unfortunately, those patients tend not to do well. So if you've had an open debridement and an Achilles detachment or FHL transfer, and you've got persistent symptoms, I don't think that Zadek is your bailout for those patients. What the bailout is, I'm not sure. But the Zadek, I think, should be the primary option, and the open debridement should be a bailout option.
You are not afraid to practice the bone spur removal percutaneously and with the.
Sorry, you're just breaking up. Could you just repeat that?
Mark, can you mute the team? It will probably stop the echo.
Perfect. My question was, when you perform the bone spur removal percutaneously, are you not afraid to create calcification with the bone past remnant and with the hematoma?
So the question is, removing that spur, can you not create further calcification? Yes, I suppose you can. And like with all the MIS work, you need to thoroughly wash out all that debris. And you'd be surprised how much debris gets created removing the spur. It comes out like toothpaste as you start squeezing. There are some patients where I do a post-op follow-up and you see some residual calcification in the area. It's a lot less than what they had pre-op, but the residual that's left behind doesn't cause any symptoms. They are symptom free, and I think that's what we're trying to achieve is a symptom free heel. So it doesn't worry me that removing the spur is going to exacerbate it or make it worse. But I think if you are doing it, you need to thoroughly wash out all that debris that's there. If it does recur, I don't think it's a clinical problem.
Sure. Okay. Mark, just a comment. Sorry, just a comment. I know you're doing a lot of Zadeks, obviously. How much do you think that it's actually a plantar fasciitis or that spur that is being redirected mechanically, as opposed to, leaving the plantar cortex intact or maybe a break in the? Sometimes you see hypertrophy of bone there after your Zadek, right? I'm not sure if you've had the same experience. So how much are you sure that it's a redirection and then it becomes symptomatic, as opposed to probably something else?
Yeah, Nasef, I think that's a very good question. I don't think we're sure it's plantar fasciitis. We're just calling it that because the symptoms are fairly similar to plantar fasciitis. Yes, there is a bit of reaction at the base of the osteotomy. You got to try and not break that plantar cortex. I think that's quite important. But yeah, I'm not sure. I haven't done any imaging to see is it truly plantar fasciitis. We just treat them with a bit of massage. But if you do have a big spur there on the plantar aspect, I do remove it. I am worried that as you're rotating, that spur becomes way more prominent, and then then you got to explain to the patient why you didn't take it out, and so I take it out as a precaution. Whether that makes a clinical difference, I don't know, but I'm not prepared to leave it worrying that it might cause problems. But you're right. Is it plantar fasciitis, or is it just a mechanical realignment pain that we're seeing? I don't know. But it is a transient problem. Very few patients have persistent inferior heel pain. It is quite transient. It does seem to disappear.
I have a last question. So if you do an MIS debridement of the spur, which will be your portal? More inferior, more dorsal, medial, lateral? You are muted, Mark.
Hi, sorry. So I go directly posterior and quite inferior, but before placing my burr there, I try and locate it with a needle, because the spur is not always dead central. It's sometimes medial, it's sometimes lateral. And by just placing a needle there, you can see where the majority of that spur is. And then I go very far inferior, directly in line with it. And I sort of put my burr on the tip, and I do like a windshield wiper maneuver over the spur. And it's quite soft. It comes out quite easily, and I'm aggressive with it. I take a fair amount of. I know I'm taking some tendon off, but it's not a large area. So yeah, that's how I do it.
Okay, thanks, man. Okay, so I think we will move on to that. And to move on, we will start with the presentation of Karolien Schwagten. Karolien Schwagten is one of our younger colleagues, but she has a lot of experience. She did fellowships all over the world, and her topic is non-surgical treatment of acute Achilles tendon ruptures. Karolien, the floor is yours.
Okay, thank you, Frederik. So the topic of my presentation is actually pretty basic. Why did I choose this basic topic? Because all the research is getting so complicated and results are getting more and more inconsistent. And that's why I wanted to go back to the basic, because we know conservative treatment is a good treatment, but what is it exactly? What is our treatment goal for conservative treatment? What are the schedules for rehabilitation? Like who does what and how? What are the complications? And then some take-home messages. So in this presentation, we go back to basic. Are we on the same page? Do we understand the same globally if we talk about conservative treatment of acute Achilles tendon rupture? So let's focus on acute. What is acute? In medicine, acute means 6 weeks. But if we talk about acute tendon ruptures, literature talks about 2 weeks. And this is because this is the acute inflammatory phase, which is 1 to 2 weeks. And this is where all the debris is getting evacuated. So before the collagen production starts. So the consensus of acute is less than 2 weeks. Further, what is conservative treatment? This is a non-surgical treatment to achieve opposition of the tendon ends from equinus to neutral. And this can be done by cast immobilization, which is a series of casting, which gives maximum protection by immobilization 24/7. However, it can cause atrophy of the muscles, joint stiffness, gait abnormality, and a risk of blood clots. The newer variant of conservative treatment is what we call functional management. The ankle is here positioned in a functional orthosis, and this allows early protected weight bearing and mobilization. This functional management goes along with a quicker return to work and sports and a higher patient satisfaction. So what is a rupture? The diagnosis of a rupture is made clinically, based on the history, sudden inability, popping sound, based on clinical examination, on the AAOS, who says there must be 2 or more clinical signs, such as a Thompson test, decreased plantar flexion, the gap. Interesting fact, though, is that the Thompson test can be false negative in 25% due to the plantar flexion produced by the intact extrinsic foot flexors. Medical imaging is useful as a confirmatory test, and then the preference goes to ultrasound, because ultrasound is a dynamic exam and more effective in identifying the location and the size of the gap. But X-ray can be useful as well, because on X-ray we can see if there's a calcific lesion, such as shown with the arrow, if there's a Haglund deformity, if we actually have an avulsion fracture, or any pre-existing degeneration. Like on this X-ray, you can also see the calcaneal spur visible. So this is interesting to know the status of the tendon before the rupture. And then the type of ruptures. So Achilles tendon ruptures show a bimodal age presentation. We have the younger patients who have healthy tendons who tear because of a high energy trauma, mostly sports. Then we have the elderly, which have a pre-existing degenerated tendon or chronic tendinosis, and they often have a spontaneous rupture or rupture due to low energy trauma. And this is very debatable because it's proven that direct healing of pathological tendon ends is oftentimes not feasible. Whether in the past we were thinking that elderly patients never need surgery, but knowing now that the tendon, and this can be shown on an X-ray who shows calcification, that the tendon is actually sick and therefore has less chance to heal, we should reconsider if conservative treatment is the best for these patients. Another study where they debrided infected Achilles tendon ruptures also showed that if the rupture ends are healthy, the tendon heals even despite a large defect present well. So should we think about an alternative for these elderly populations? Should we consider surgery with healthy tissue? So this is something to discuss. And if in doubt, we should do an X-ray and discuss it with the patient as well. It's also important the level of rupture. If the level is at the musculo-tendon junction, conservative treatment is always a good option. If it's mid-tendon, where there's a poor blood supply, there are arguments for surgery and arguments for conservative treatment. If we have an avulsion fracture of the calcaneal tuberosity, such as one of these types, for example, we always need to do surgery. So now the definition of the title of my presentation is clear and there's consensus. Let's talk about our treatment goal and what we actually want to reach. So our treatment goal is to restore function and strength of the tendon, enabling the patient to return to normal activities while preventing long-term complication. So how do we do this? To restore function, we need apposition of the tendon ends, and this can be done by appropriate positioning, equinus, in an orthosis or a cast. And multiple studies have been done where they checked different types of orthoses. This is an interesting study where they check how the gap closes, for example, in an equinus cast, in a boot with 3 wedges. And what they saw here is that the equinus cast gives the best protection. So the gap of the Achilles tendon rupture is minimal in the equinus cast. Then next in line is a 3 wedges, but if there's only 1 wedge, the gap can go up to 2 centimeters. So equinus cast is still the best protection to close the tendon ends. In these other studies, they compared different types of boots. On the left, you have the Vacapet boot, and on the right, you have the classical boot with the wedges. And if they did x-rays of the ankle in these boots, we saw that the Vacapet produces nice equinus at the ankle and therefore gives better apposition of the tendon ends than the boot with the wedges, where on the right you see the equinus is mostly produced at the midfoot. So how do we restore strength? Restoring strength can be done by weight bearing, because weight bearing promotes tendon healing and maturation of the tendon. We can also apply progressive resisted exercises in the varying degrees of the ankle. And then a newer technique is blood flow restriction training. And this is restricting blood flow while exercising, and this is done by utilizing a specialized cuff. This training has a similar effect as high load resistance training. It can prevent muscle loss during inactivity and is especially useful in the early phases of rehab. It tends to give a faster and a less painful recovery. There are different phases of blood flow restriction training, and it starts in rest, then walking, following by low load exercises, and last with high load exercise. On the photo on the right, you can see this specialized cuff used. However, this is a technique that can only be used by trained physiotherapists, so please do not try this at home. How can we prevent long-term complications after conservative treatment? Apply DVT prophylaxis. Patients are walking in the boot, however, their gait pattern is not normal. So apply DVT prophylaxis. Secondly, consider well if conservative treatment is actually the right indication. Conservative treatment is not ideal for competitive athletes. There are some studies who show less plantar flexor strength and more re-rupture rate, specifically in the competitive athletes group. In other population groups, the re-rupture rates in most of the studies is the same. We don't apply conservative treatment for calcaneal avulsion fractures, neither for chronic ruptures. And then last tip is do not rush the treatment. Slow and steady wins the race, so you have to respect the time frames of tendon healing. You have the acute inflammatory phase, then the proliferative phase where the type 1 collagen production starts, and then a very, very long remodeling phase up to 18 months. And the greatest tendon elongation, despite weight bearing or non-weight bearing, is between 2 and 6 weeks. So you should absolutely avoid dorsiflexion past neutral until 8 weeks post-trauma. Also, when the patient asks you when they can sport again, you should consider return to sport as a continuum. Never say a specific date, discuss it with the physiotherapist, check the speed of their rehab. It is a continuum, not a moment in time. So next step is some rehabilitation schedules which are widely used. The first one is the SMART protocol, published in the GBGS in 2015. This is a protocol where they use the Vacoped boot. They start with the equinus cast, where they actually allow full weight bearing in the cast, then followed by the Vacoped boot, and there is protection up to 10 weeks in this one. This is studied on a big population and shows only a re-rupture rate of 1% in surgical group and in the conservative group. The next protocol is the LAMP protocol. Here they also use a Vacoped boot, and they start with the Vacoped boot immediately in the emergency. The boot is removed at 8 weeks in this schedule. This has also been extensively studied with a re-rupture rate of only 2%. A more recent study is done in Norway. It does not have a name. It's published in New England Journal in 22. They start with the plaster of Paris in equinus. They go in a brace, which is not defined which one. And after 8 weeks, they go out of the brace. In this study, there's a higher re-rupture rate, which I cannot explain why it's in this one and not in the other one. So the results of re-rupture rates are still inconsistent between the rehab protocols, between the different studies that have been done. This is an example of a local foot and ankle surgeon. So mostly in the emergency service, a cast in equinus is put on non-weight bearing. Then the patient is seen in the outpatient clinic and is discussed whether surgery or conservative treatment is the best. If conservative treatment is chosen, the cast is removed and an Achilles boot is put on with 3 wedges, which is 30 degrees of plantar flexion, and full weight bearing is allowed. The wedges are getting diminished over the weeks. And then after the 8 weeks, we allow a period of 1 to 2 weeks to let them diminish the use of the boot according to their own speed. Return to sport is also according to the treating physiotherapist. It is a continuum, as said before. So what can go wrong with conservative treatment? So orthosis can give skin lesions. And beside that, a lot can go wrong. A lot. You can have an accidental trauma. You can return to sports too soon. Patients or physiotherapists can be non-compliant with the protocol. Patient can have a poor healing capacity. The foot can be improperly positioned in the orthosis or in the wrong orthosis. We can have inadequate strengthening, too much stress on the healing tendon. We can have the wrong indication. So lots of things can go wrong. But does that mean it's the wrong treatment? Who knows? Because of all these things can go wrong, you can have a re-rupture, an elongation of the tendon, and therefore less strength. You can have a deep venous thrombosis. So what are the key messages I learned after making this presentation is that equinus cast is actually a really good treatment and it's the best choice at start. So if in doubt, always start with equinus cast, non-weight bearing, and leave it on for a bit longer until you know what to do. And then if there is a rupture of a pathological tendon, consider with colleagues or with the patient if surgery with healthy tissue might be superior than conservative treatment. Another point, do not rush. Avoid this dorsiflexion past neutral for at least 8 weeks, but also consider adapting the time of the rehab protocol in function of the patient's healing capacity. If the patient needs 10 or 12 weeks in the boot, that's fine. They don't have to throw away the boot at 8 weeks. They can stay in for a bit longer if necessary. The indication for the type of treatment, surgery versus conservatory, is multifactorial, and therefore this is a patient-informed decision. But you as a surgeon can help to inform the patient to your best knowledge. And then, for example, I showed these 4 rehabilitation schedules. You have to see which type of rehab protocol would work in your local practice for your type of patients. So make your own rehab protocol that works, where you get the physiotherapist to work with you and your colleagues. Good luck. Thank you for your attention.
So thank you very much, Karolien. My colleagues here were very impressed by your presentation, and so was I. We need to move on to Arne Burssens. Arne Burssens has to attend the promotion of Matthias Walcher, his PhD student. So I hope you're there, Arne. We had some technical problems.
Karolien should stay for discussion later.
Yes, please.
Maybe, Karolien, if you can stay for discussion later on. So meanwhile, I have a question for Karolien. So you talked about acute, it means upon 2 weeks. Is this a hard deadline for you? What about 3 weeks or 4 weeks or 2 weeks and a half?
I think 2 weeks is already very long. In my personal experience, if the patient comes in after 1 week, I'm already doubtful if I still want to imply conservative treatments. But this is what the research says. They take a cutoff of 2 weeks. But I'm not sure if that's what you need to imply in your practice. I would go shorter.
So if they come later than 2 weeks, you will consider surgery? Does this mean?
This means that they have not been protected the first 2 weeks, and the gap is getting bigger and bigger. So there's less chance of the tendon ends coming together with a cast or a boot.
Yes, Karolien, thank you for your presentation. Very nice. Can you precise, please, what is return to sports at 3 months? What does it mean?
So this is what I was actually saying. It's not return to sports at 3 months. It's a continuum. It's you're in treatment with a physiotherapist, and a physiotherapist goes step by step. You first start to learn to walk, then you start to learn to run at a slow pace, so it's all these steps in training, and the physiotherapist should prepare you to your sports that you do specifically. And I think you should give this responsibility to a good physiotherapist.
Okay, thanks.
I have a question about the boot and the functional recovery. So how long do they need to keep the boot during the night?
Good question. I don't think we should rush into this. If you do not trust the patient, keep them in the boot at night as well. If you think this is a very compliant patient, maybe after 8 weeks, after 6 weeks, you can say not during the night, but the first 6 weeks, I would say day and night for sure. But again, if this is only for the comfort of the patient at night for 2 weeks, I'm not sure it's worth the extra risk.
Okay, if you would have a very incompliant patient, so a very unreliable guy, would this change your treatment? Would you keep them longer in a cast, for example?
Yes, and I think this is what I learned from making this presentation myself, that an equinus cast is actually the best protection. So if you do not trust the patient, keep them in an equinus cast for 3 or 4 weeks and then start the functional rehabilitation with the boot for 8 weeks, or consider going from 8 weeks up to 10 weeks boot. So have a low threshold in elaborating the treatment protocol according to the patient which is in front of you. Make it longer rather than shorter.
I have one question. do you have specific tests, clinical tests, or what do you use to say this patient is going good and I'm moving to the next step to give him more freedom to do more exercise? What is your test? What you would like to see after 6 weeks or 10 weeks?
Yeah, so I see that whenever they come in clinic, I put them supine. I check if the gap is closed. For example, if I still clearly feel a gap at 4 weeks, I would even reconsider going to surgery. Because if the orthosis or the cast has been put on properly, you shouldn't feel a gap at 4 weeks. The gap should be closed. There should be a continuum of the tendon. And then I try the Thompson. If it's negative, or even if there's a slight connection, that's a good sign, and that means you can go up to the next step. However, it is a gray zone. It's hard to answer your question when to go to the next step. So sometimes you do just have to take the risk to continue the treatment.
Okay. Apparently, Stefan is available, so we will move on to Stefan, the BFAS president. He will present without camera to avoid further technical problems. Thank you, Karolien.
Thank you. Great talk.
Is that okay?
That's perfect. We're running.
Okay. So,
That's great. The floor is yours, Stefan.
Yeah, thank you, Frederick. So the point I was trying to make is that, well, there's still a lot of studies that need to be done, and I think that we should focus on indication, and that we have to focus on doing the right treatment for the right patient. Interesting from the study in the New England Journal of Medicine, where they saw that there was no difference in functional outcome. What they did see was that there was a high chance of re-rupture in the non-operative treatment compared to the zero, so or almost zero amount of re-ruptures in the surgical repair group. So I think that the point there, second point is that what we do see is that there is a higher chance of adverse events in the surgery group with, for example, nerve injuries, which are quite high in the minimal invasive surgery group with 5%, and also wound healing problems that are observed in the open repair group. So we have these pros and contrasts for surgery and for conservative treatment. And there I think the point is that if you do surgery, if you consider surgery, make sure that the indication is right. An older inactive patient will not benefit as much of doing a proper suture than a young, healthy and active patient. But if we do surgery, we should try to avoid any types of adverse events, because this will inevitably also diminish our results or make the results worse. So in this regard, I tend to do a mini open repair of Achilles tendon ruptures. And the idea is to have a very strong rupture without disrupting tendon healing. And what I mean by that is that I want to keep the biology of the healing intact as much as possible, but I will also demonstrate that later on. I want to have a suture that is able to withstand early weight bearing without the chance of re-rupture. I think the 7% that was mentioned in the New England Journal of Medicine study is too high. If you have a young active patient in front of you, 7% chance of re-rupture would be a disaster for this patient. So that's really a good argument to do an operation, and a good argument to have, if you do an operation, to really have a good, strong suture. You want them to do early strengthening exercises, because then they can have a full recovery in a shortest period as possible. In doing so, we should definitely avoid surgical complications, and the main indication or the main complications that we come across are the nerve injuries, especially in the minimal invasive techniques, and obviously also wound issues. So for that, I tend to do a mini open Achilles tendon rupture, because I think there you will have the benefits of having a strong suture together with avoiding the disadvantages. What I do is, this is a marking of the rupture site. What I tend to do is make a proximal and distal incision of about 3 to 4 centimeters. I dissect up to the parathenon, and importantly on the proximal side, I look for the serralis nerve. I think that's one of the first major advantages of doing it mini open, that you still see the nerve and you are able to avoid it and prevent any problems there, which I think is still a big problem with the minimal invasive surgery. I do the same on the distal part, where we expose the tendon and make sure that we don't come across the serralis nerve on the lateral side. What I tend to use is a non-resorbable suture. I tend to use a fiber wire too. I make a loop from it, so I have a loop with 2 strands. And at the proximal side, I use locking sutures 3 times on the proximal side, and I do this twice. So I make 2 loops 3 times, a locking suture on the proximal side. Then I cross it using a cocher. And the idea of crossing it is that you keep the hematoma intact, you keep the paratenon intact, and also importantly, you leave the skin intact. In most cases, when you see wound issue problems, it will be at the rupture site, so you can avoid this by using this sort of technique. The second thing is that you leave the paratenon intact, which will be important for a good biology of your healing, and you also leave the hematoma intact, which again has an important role in the healing of the tendon. So on the distal side, I do 2 running sutures with a double strand, so 1 loop, 2 double sutures, and then I lose 1 branch and I do 2 other running sutures. I do the same for the second loop, and so you have 4 strands coming up at the distal part. Then I tie them and I knot them, and I make sure that the position of the foot after knotting them is in the correct position. What I think is very important, that if you do an operation, I think it needs to be a firm and solid suture. For this, I like to do, obviously, the Thompson test, but I also use resistance and force, just to make sure that you put good strength and good force on it, just to test your suture. If it doesn't hold, the idea should be to redo your suture, because you really have to have an advantage of your operation, and you really need to have a good suture so that you can allow them to start a rehab as soon as possible. Then I do some washing and I close up the wound or the skin. And the post-op protocol is a cast in equine for 2 weeks, elevated, non-weight bearing. Then afterwards 4 weeks with a walking boot with heel wedges, where I take 1 heel wedge out every week. And at 5 weeks they are allowed to go to 9 degrees within the walking boot, and at 6 weeks I allow them to start walking and allow them to start their loaded rehab. So in summary, I tend to do only Achilles tendon ruptures in patients that benefit from having a full recovery of their function. I also try to avoid any complications looking at indication. I try to avoid patients with comorbidities and things like that. And if I do a suture, I try to avoid any complications, wound problems, nerve injuries, and keep the paratenon intact. And I really want to have a strong fixation, which I think is also a major advantage of keeping it open. Sorry for all the technical disturbances. This technique, I'm gonna try to write it down in a short report, but if you have any questions, please do not hesitate to contact me, or feel free to ask me anything afterwards. Thank you.
Thank you, Stefan. That's a great presentation, very innovative. So this morning we talked already about paying attention to the hematoma. When we were talking about arthroscopy, now you are demonstrating how we can do sutures and keeping the hematoma. We give it another try to go to Arne.
Oh, thank you again for the invitation. We're very honored to present our work. So I'm Arne Burssens. I work as foot and ankle surgeon in Ghent University Hospital in Belgium. And this Achilles tendon research has been near and dear to me because I've been doing it since a couple of years now. So I think as an introduction, we can state that the mid portion of the Achilles tendinopathy is situated between 2 to 6 centimeters from its insertion. We know that it's quite a prevalent condition, especially in elite runners. And we have seen throughout this conference that there are numerous treatment modalities, but all of them with little evidence. And I think this reflects a bit the underlying pathogenesis that we don't understand. So over the last years that I've been doing this research, I think these 3 factors now hold really promise for me and have been the topic of many interesting studies. So first is the inflammation. When I started doing research on Achilles tendinopathy, it was always defined as a tendinosis devoid of inflammatory cells. But when we're going to the current literature, we see with the techniques that are getting better that we can analyze our inflammatory cell types differently and in more detail, and then we can see that there are more inflammatory cell types than we would have think. So I think for sure this could be for the future an interesting target, and it's definitely mechanically bound. And this is now in one of our papers that you can see that this mechanical stress is an important component to induce this inflammatory cell types, as you can see here in this diagram. And this fits into this concept of the pathogenesis of Achilles tendinopathy with its mechanical components. Another type that we're looking at is the pressure. So as you know, the tendon is surrounded by the paratendon, and this forms a sheet or sheet-like structure. And if a structure is swelling, for example, when there are more gags coming into the Achilles tendon, it attracts more fluid and the intertendinal pressure is rising. So this means that it gives a higher pressure in the tendon, more compression on the tenocytes, which are not used to it, so they transform their shapes. And we partnered together with this team here of, amongst others, Jill Cook, who you all know, that have been describing this continuum model, and she saw that it fitted perfectly that we add this component of pressure in the Achilles tendon. In another study, we used specimens and we ejected the Achilles tendon with hyaluronic acid, with a typical gag. And interestingly, of course, that's something that we expected, the pressure rose. But when we use enzymes that attacked those hyaluronic acids, we saw that the pressure decreased. So that could be also an interested target to use this in our patients to reduce the pressure in the Achilles tendon. This pressure in the Achilles tendon has also been depending on the type of twist in the Achilles tendon, because you know there are different types of twists of the fibers in the Achilles tendon, and some of them really were more prone to higher pressure. So this could be, for example, interesting in athletes, where we could do MRI analysis and see which kind of type twist they have and prevent them more for Achilles tendon injury if they would be more at risk of developing higher pressures. And in our last study, we started to do these measurements in vivo, and then we found out how high this pressure already is when we are just doing plantar flexion. So this for us was an indication, because nowadays more and more treatments like high volume injections around the Achilles are recommended. But we think we have to be careful with that, because it could increase the pressure around the Achilles tendon. And one last part that we are looking forward to and really starting now, it fits well with the Achilles tendon ruptures that were described by Dr. Stefan Clockaerts and Dr. Karolien Schwagten, is that we're using the blood flow restriction rehabilitation for our Achilles tendon ruptures. So for those who are not completely aware with blood flow restriction protocol, so you could see here that a cuff is attached around the thigh of the patient and it gets inflated, so it gets a decreased blood flow towards the lower leg. And this gives a ischemic response in the lower leg, and this stimulates very much a healing response. So it's been out there for a lot of other implications, like problems and rehab in the knee, rehab after ankle fractures, and now we're really utilizing it for Achilles tendon ruptures. Because in the beginning, we all know that when the patients after Achilles tendon rupture go to the physiotherapist, they cannot put high loads. And that's exactly what the blood flow restriction does. It allows you to do low loads under this reduced blood flow so that you get more effect of this low loads getting on your lower leg. So I think as a conclusion, of course, we all know that's a difficult condition to treat, but there are some new therapeutic targets out there that I think were interesting to share on this Global Achilles Tendon Conference. Thank you for your attention.
Thank you, Arne. This was a great presentation. So this is very important, those basic science things. So we need this to improve our treatments. So I'm sure there are some questions.
So what is the clinical application of the problem of the pressure? Do you think we have to create some tests?
So one clinical implication
Yes.
could be like that we saw we have an increase of these gags in the Achilles tendinopathy, and that we use the enzymes to reduce these gags so that it can reduce the pressure. That could be one clinical implication. Another one could be maybe that it is beneficial to release the paratenon around the Achilles tendinopathy, which in some studies shown have to be beneficial, and this could be an explanation because the pressure around the tendon is reduced.
But do you think we have to use it with all tendinopathy, Achilles tendinopathy, or we have to select some patients?
Yes, I think that's indeed a good point that we develop, because now we establish some normal reference values of what is the intratendinous pressure with this small needle. But in
my question. And how to assess the intratendinous pressure?
this is with a small needle here.
Okay, with
You
the
see,
needle.
this is very small, and now we have reference values together with Dr. Pringles. He focused his PhD on that, and those small needles can be used to detect maybe those patients that have a very high pressure, and those could indeed maybe benefit more of this paratenic release.
And what the percentage of patients with tendinopathy you find with high pressure?
This we still have to define. We now tested the cadavers and tested in normal subjects the normal pressure, and now we're going to stratify the patients with the midportion Achilles tendinopathy. But it's sometimes the preliminary data that we have can be up to 10 times higher than the normal pressure. So it is quite impressive.
Would you say we could find typical signs in an MRI or clinical examination? This is a patient who has higher pressure beside other patient with tendinopathy. Could you imagine there would be some typical signs?
That is indeed a very good remark, and still something that we need to find out. But we're looking into that to see at those patients having high pressure. We always take an MRI, and then we're going to correlate those findings to see if they maybe have on the MRI more intertendinous fluid or things like that, and that could be a sign that it could be better to have this release.
Because we have patient colleagues, they're doing arthroscopy release, and I'm always wondering what they do exactly by that technique. So maybe if there's a high pressure patient, this is going to help.
Yes, for those, but maybe in some it isn't the problem, and then the release wasn't maybe not necessary. But now maybe if we could quantify it better, then we could have a better patient selection.
It's a really good point. Really, I like it.
But we still have to continue the research.
I have one question. Have you found any relationship between what you found and orthobiologics, let's say PRP, hyaluronic acid?
So
biologics, there's some relation between them?
For those hyaluronic acids, we would not advocate for it because it's one part of why the intertendinous pressure is rising. But oppositely, enzymes that would diminish the amount of glycominic acids, that would be an interesting target, so that those could be reduced in the Achilles tendon.
Okay, thanks.
I have another question to the tourniquet. Is this the same way like flossing working? But we know the flossing works in a physiotherapy technique. Is this the same way of thinking? You know, flossing, where you wrap up with the S mark or something the whole leg?
This could be similar, but I know it's like a tourniquet that we use during surgery.
Yeah.
And we can set, because during surgery we completely cut off the blood flow to the lower leg, but with the blood flow restriction, we can set it, for example, to around 60% of restriction. And I think by this you still have enough blood flow, but your lower leg gets this response, oh, I really have to do something towards the healing because I'm working here. It's like a training in a high altitude where the oxygen levels are lower, that your body says, okay, now I have to make more EPO so that I can train better in these circumstances. That's a bit the idea behind it.
But I read always there's neovascularization, a sign of inflammation and pain. Would you go this way?
Yes, but that's in the mid portion Achilles tendinopathy, but we're now using it for the ruptures, the BFR. But there are some groups starting to use it now for mid portion Achilles tendinopathy, and indeed there is the angiogenesis a factor. Some consider it as something bad. Some considered it maybe that it's a sign that it's necessary but not working. So we still have to find out if it's working in the classical mid-portion Achilles tendinopathy.
But isn't that theoretically the way that the shockwave would be treating, like doing micro trauma that stimulates healing, but also the longitudinal incisions, the needling? It's the same concept, isn't it?
Yes, exactly. But it maybe induce some other factors, of course. For us as surgeons, those healing reactions all look the same, but from a basic scientific point of view, these trigger different kind of factors that have other responses. But that is still something we have to find out. That is true.
So I think we should leave Arne to go to his promotion meeting of his PhD student. Thank you very much. I think we should invite you again in 3 years when we are going to do the next global webinar focused on Achilles tendon.
I'll do my best with some more explanations by then.
Okay.
Thank you for the interesting discussion. Bye-bye.
Really inspiring.
Bye-bye.
So great talk. I don't know if Stefan is still there. If he's not there, we need to move to a case discussion.
We have time to discuss one point, and this is quite simple. I found this yesterday in the presentation from a colleague, and oh no, sorry again. We have a comment from the we have a comment from the panel. Neovessels and angiogenesis are completely different. Inflammatory-ness not good vessels. Okay, this is clarifying what we misunderstood. Thank you for this comment. We're going back to this slide. And we heard this today quite often. That we have different time frames. Maybe we can, would you say the faculty, this is something that you can work with it?
I think those phases of healing are very important. But I think the time frame should not be taken so strict. For example, if you are in the inflammation phase and you continue walking and you don't care about it, you remain a longer time in this inflammation phase. The same with an ankle sprain. If you keep walking and if you don't pay attention for the healing process, you stay in this inflammation period. Well, it's actually more important to move on to the next phase of wound healing. This is the same of surgery. If patients don't keep their foot elevated and take a little bit rest, they don't arrive to the next phases of wound healing, and they continue to have pain, swelling, and inflammation. So I think we as clinicians should be experts in assessing the position of each patient regarding these processes of wound healing.
And control comorbidities, because also, for example, tobacco will modify this timeline.
how would you adjust if you're doing a cast? How you respect this flow, this with the cast?
So I think if the first days, several days, you keep your foot elevated, you don't move too much, you get rid of the swelling, you move faster to the next phase of wound healing. And younger patients will move on faster.
I'm just thinking about conservative. If you, but how you address this with the cast? You cannot, is it?
You can tell your patients take a rest the first days.
And then?
They will have less pain, and it's a sign that they are moving on to the next phase. So I would recommend to take no antiphlogistics. It's more and more, it's less and less recommended, and take a rest, because the pain and inflammation, the pain is an alarm system. So if you cut off your alarm system with a lot of medicaments, you don't feel that you are overusing it and continue lengthening these phases of wound healing. So I think it's important.
Okay, but after inflation, how you change your regime? You change something? They can, how we can address, we know this and we would like to address it and get a benefit, because we heard the Achilles is your friend. He wants to heal, but how we can help him with the cast for 6 weeks?
I think there is a clear difference between 4 weeks and then after.
Yeah.
For me, we must take care up to 4 weeks. That would be the limit. Maybe it's 5, maybe it's 3, but we must be around 4 weeks. Take care of the equinus and the position or whatever.
So you usually see the patient
that will be the second
this moment.
phase. We have to take care until the end of the proliferation phase.
Yeah,
it seems reasonable.
I think you can assess the difference, as Karolien explained. If you examine the patient and they have some little bit power, the gap is closed, there is not so much swelling, it means that they were succeeded to move on to the next phase of wound healing, and they arrive in the proliferation phase.
If you palpate the tendon more or less 4 weeks, you can feel something in the gap. Yes, I totally agree. Maybe it's not a huge whole tendon, but you're touching something.
The patients will tell you, they say, I have less pain, I have no problem to walk around a little bit with crutches, I feel fine.
And what's important is to have biomechanical stimulation during the collagen production time. So from 4 weeks, and then we have to give stimulation in the wrong
loading.
In the good way. Yeah. So before 4 weeks, probably it's better to be safe.
Yeah.
And I still don't think these are very clear cut. I mean, you can't say that inflammation definitely ends after 10 days, for example. And you can't say proliferation would never.
There is
There's an overlap. And so still again, you will individualize it to what you're seeing, what the patient is experiencing. But I think, like Javier said, your cutoff between something acute and then building is at that 4 week or 6 week
thing,
and then you can be more comfortable loading.
Yeah, I think you should allow loading, so you get a little bit stress on the structure to develop in the right direction, to get the, like in a bone, it's the same base to go this. It's so. This is one thing that we can discuss.
But I think if you go too fast in the proliferation phase, you can go back to the inflammation phase and feel at a certain moment more pain because you did too much. And if you're lucky, you can move on again in the good direction to the proliferation phase.
Are there any additional things that you would use during that time, like PRP? Shockwave, something to support this journey for the.
If you are in a normal repairing phase, you will not need anything. I would rather use that when something happens, something is wrong.
Yeah.
But it's like the bone, as you said. It's a proper healing. Just wait.
You can use physio to reduce the edema, for example.
Yeah, but this is
current
not
for
really helping the
sports.
tendon. Tendon is just physiologic.
Yeah,
repair.
but no, we will help to go from the inflammation part to the proliferation, to reduce the time of
Are you
inflammation.
using PRP for acute repair, let's say? No. So that's what I'm saying. The tendon doesn't need that. Instead, it needs, let's say, I don't know.
I think the first weeks is not necessary. There's so much blood already there.
And because there is a stress of the cells during the acute time, PRP can't work. So to use PRP, we have to wait the homeostasis of the cells. So it's around 4 weeks after a trauma. And it's the same for the surgery. For people who are using PRP during the surgery, there is no effect. You have, because of the stress cells, it can't succeed. So you have to start to wait until the homeostasis, so 2 weeks later.
And shockwave? Do you think shockwave after 6-7 weeks is an option?
No
I
experience.
think it's for tendinopathy, but it's not for acute phase or...
I'm using it
even
if
repair,
I feel they're stiff, but they're not allowed to do extension therapy. So I'm using it as add-on at that time period. After 6-7 weeks, I don't like them to do stretching. So to get the tendon a little bit weak.
And in which way should this work to improve the healing process?
The fibroblast, it's just, there's no study in my hand. We have later a great talk from Karsten Knobloch about this. We have to ask him. He is a really experienced shockwave user, but some patients, you feel they're a little stiffer than you would like to have, but on the other hand, you cannot go to say, do a stretching after 6-7 weeks. So in those patients, I would like to use something to add on. This is, but you cannot do stretching. Probably this is what we have to take the question to Karsten Knobloch.
Okay.
So I think we are good in time. And we take a 5-minute break and then we go on with Germany. Germany is there with great talks and we'll be back in 5 minutes. Okay, Hans is disconnected. Matthias, I have seen you. Could you jump in and then we take Hans later? Is this possible?
No worries. My talk should be pre-recorded, so I do not expect really many technical issues.
Good. Could we start the presentation from Matthias Walcher? Yeah, that would be great. Yeah, it's pre-recorded.
Dear faculty, thank you very much for the invitation. Ladies and gentlemen, my topic for today is Achilles tendon rupture, non-operative treatment. These are my potential conflicts of interest. None of them is related to this topic. The Achilles tendon is the thickest and strongest tendon of the human body. Ruptures are very common. There has been an increased incidence in the last years. Patients are usually over 30. It is quite typical in athletes and in professional athletes, like in the weekend warriors. Residual complaints after treatment are frequent. We already have been able to identify predisposing factors like gout, hyperparathyroidism, steroid injections, and fluoroquinolone treatment, and there is an ongoing debate as to the ideal treatment. Achilles tendon ruptures are a potential life-changing event, in particular in athletes. In professional basketball, about 40% of the players will never return after an Achilles tendon ruptures, and the returning players will have significant decrease in playing time and performance. Likewise, in NFL football, about 32% of the players will not return after an Achilles tendon rupture and show an average reduction of power ratings of more than 50%. This shows already that outcomes are not typically perfect, and traditional issues are re-rupture rate, infection, wound problems, nerve irritations, function scores after repair like after non-operative treatment, and in the modern times in particular, weakness, tendon length, return to work and return to sports. On the one hand, there's the operative treatment, where we hope for a better result, for an excellent control over the tendon length, although that is not 100% proven, for fewer re-ruptures, for a faster recovery, and we have an increased risk of infection, the risk of nerve irritation, in particular of the sural nerve, and the risk of adhesion of the tendon. Non-operative treatment, on the other side, shows less complications, but a higher rate of re-ruptures and a worse function in sports. Still, there are some general considerations that need to be taken into account. Are the high re-rupture rates of non-operative treatment based on historic data? In short, does modern non-operative treatment do better? Is there a one-fits-all solution to the problem at all? Are all patients the same? Are all ruptures the same? So it makes sense to compare operative to non-operative treatment. If you look into literature, there's a high incidence of DVT after Achilles tendon ruptures, and it is roughly the same, be it with a non-operative like an operative treatment. The Achilles tendon performance scores are similar in the operative patients like in the non-operative patients. There's no difference in symptoms, but surgery restores calf muscle strength earlier. At the 18-month follow-up after rupture, there's a 10 to 18% strength difference favoring surgery. The high-speed isokinetic strength favors surgery, and after surgery, there's a better hopping and drop counter movement jump. So, in particular for high-level athletes, surgery obviously seems to offer advantages. So, to put it to other words, which ruptures of the Achilles should we treat operatively? Of course, open injuries, Achilles insertional and avulsion injuries. We know from literature that they are not doing well if we treat them non-operatively. And for all the other Achilles tendon ruptures, the most important decision maker is the ultrasound. What we need for proper conservative treatment is tendon stumps that need to oppose under ultrasound. So what we want is less than 1 centimeter gap between the tendon stumps and no overlapping. The non-operative treatment requires a functional rehabilitation with a very rigorous protocol. And what we know is that non-operative treatment only has an increased rate of re-rupture if there is no functional rehabilitation with an early range of motion exercise part. So if you do not have the option for a functional rehabilitation, which requires specialized physiotherapists, you should opt for surgery. Surgery still has potentially better results in the sporting population, but if you opt for surgery, minimize risks and go for MIS if possible. It makes absolutely sense to follow a dedicated treatment algorithm, and one that I have made particular good experience with is the SMART algorithm from the UK, because it is very well scientifically evaluated. It shows a low rate of re-rupture, a satisfactory outcome, a reduced rate of surgical intervention, and a reduction in healthcare costs. Operative treatment is an option only for patients less than 55 of age, with a complete rupture of the body of the tendon that does not oppose under ultrasound, so basically has a gap more than 1 centimeter even in passive plantar flexion. All the other patients go for a non-operative treatment, and the rehabilitation protocol is identical for operative like for non-operative patients. Patients should receive specific therapy within 48 hours after the injury, and the first time after the injury there is the immobilization period. So patients will have 2 weeks of immobilization in plantar flexion in a position where the tendons are well opposed. Then 8 weeks of vacuoped immobilization in different positions. TheraBand exercises start like 5 weeks after trauma. Make sure that there's no dorsiflexion beyond neutral. And from 4 weeks after the injury, blood flow restriction therapy shows very well results and very nice recovery of the muscle strength. Mobilization starts about 10 weeks after the injury and follows a very detailed protocol. I do not want to go into too much detail because this is mainly physiotherapist work and not so much orthopedic surgeon work. Still, I think it is important that we as orthopedic surgeons know about the underlying ideas to make sure that we counsel the patient well. Patients should avoid extreme dorsiflexion for 5 months, in particular in combination with active plantar flexion following. Hopping and return to sports at the earliest about 6 to 8 months after the injury, and there is defined criteria for return to computation which make sure that the injury risk and the re-rupture risk is as little as possible. Mechanical stimulation of the healing tendon is mandatory because then the callus of the tendon gets larger and stronger. COX inhibitors should be avoided during the inflammatory phase because if you don't, you'll have less fiber strength and less bone tendon strength. On the other hand, after the inflammatory phase, you should do COX inhibitors because they're going to be resulting in improved tendon healing and have a positive effect on mechanical properties. PRP injections will strengthen the tendon about 30% in the animal model, but still require mechanical stimulation to do so. What should be avoided is pain that lasts longer than 3 hours after the rehab, pain of more than 0 to 2 VAS pain during the exercise and stimulation, and any swelling and clinical sign of inflammation during the exercise. In summary, most Achilles tendon ruptures can be treated non-operatively. Ultrasound is the most important decision maker. You should follow a dedicated functional treatment regimen. It requires a special infrastructure. Surgery is indicated if there is a persistent gap in plantar flexion in the ultrasound of more than 1 centimeter and in high-level sports people. There's the best result if surgery is done within 2 weeks after injury. You should go for a functional and aggressive rehabilitation, and if you need to do surgery, opt for MIS if possible. Thank you very much.
Great, Matthias. Thank you. Great talk. And we have some questions already, but we will wait till we finish the whole session and then we'll discuss together. We're going directly to the talk from Kajetan, which is also pre-recorded. So we go on with the talk of Kajetan Klos, non-operative treatment of midportion tendinopathy. Kajetan, it's your floor.
Dear colleagues, my talk is about the non-operative treatment of midportion Achilles tendinopathy. It's widely known that this tendinopathy is triggered by overuse, and so top runners have a risk of 7 to 9% for getting an Achilles tendinopathy. But it's also often seen in middle-aged obese patients with no reported increase in physical exertion. As a pathogenic factor, the blood supply is considered to be a cause of midportion achilliodynia. And so we could show in one of our studies where we measured the microperfusion of the Achilles tendon that there is a reduced microperfusion 5 centimeter proximal to the insertion. And there is a negative correlation between age and blood flow in men. That explains the localization of the achilliodynia and also ruptures, and for us also explained the high incidence of Achilles tendon pathologies in men in the 4th and 5th decade of life. And it has been shown that the pathology is not inflammatory in nature because there's no prostaglandin-induced inflammation, but it is rather a failed healing process. And the source of pain is based on the sprouting of nerves and vessels from the surrounding tissue into the tendon. So I want to go on with the therapy now. In general, it is to be said that spontaneous recovery after more than 6 months of symptoms in tendinopathy of the tendon is unlikely. Where are our lever arms in therapy? First, we can look for better microperfusion, for better healing of the tendon. We could look for better tendon strength, less mechanical stress, less neurovascular sprouting, and a better gliding of the tendon. So I want to discuss the treatment options we have nowadays, and I separated them into different groups like modification of activities, medical aids, pharmacologies, mechanotherapy, and physiotherapy. And I want to give the evidence levels for these treatment options, and I separated them in 3 groups. First group is evidence against it, so we should not do it. Then we have some evidence, so that means we can do it, and there are some treatment options that also have a high evidence, so we should do them. And at the end, I want to give an example of my way to treat Achilles tendinopathy. So let's start with the modification of the activities. It's shown that the functional therapy is superior to complete immobilization. so we have evidence against complete immobilization. But there is some evidence that sports should be reduced to give rest and reduce inflammation until symptoms disappear, and then gradual increase in load should be started again. To come to medical aids, here we have night splints, for example, but they have shown to not be effective. But what can help are special bandages. They have proven to be helpful in multiple studies, and it has been shown that they work best combined with other therapies. So I want to go on with pharmacologics. Here we have non-steroidal antirheumatics, for example. It has been shown that they inhibit the tendon cell migration and proliferation, and double-blinded studies have shown that there is no effect on the clinical symptoms, so there is some evidence against the use of these drugs. Then we have nitro, which can be topical used as a patch or a spray. The idea is that oxygen radicals stimulate fibrous proliferation, and the nitro patch can support tendon healing. Several studies have shown the benefit of using nitro, so there is a strong evidence that nitro can relieve pain and increase tendon strength. Now I want to go on with injections. Here first cortisone has to be discussed. Cortisone injections can lead to quick symptom relief, but in the long term there can be serious side effects, for example, spontaneous ruptures, so cortisone is expressly not recommended. So I want to go on with PRP. First, it has to be said that PRP is contradictory discussed. This study, for example, shows no benefit for PRP compared with a control group. However, there are also studies that describe a positive effect. In general, it can be said that no negative side effects have been described up to now, so that PRP is still often used. Going on with high volume injections, the idea is to destruct the neurovascular connections that grow from the paratendon into the tendon and to get a denervation and release of the paratendon. Also, there are some studies that show very good effects. It has to be said that the study situation is not yet such that a general recommendation can be made for that. A newer treatment option is the use of stromal vascular fraction. Here is one study available that shows that SVF is better than PRP, but with only one study, a general recommendation cannot be given up to now. The use of hyaluron injection is also described to be helpful, but again, there are not enough studies to give a general recommendation. Another option is sclerotherapy under power Doppler. This procedure is technically complex. Here we have an evidence level of 1B, but here too there is no general recommendation up to now. Now I want to go on with something we call mechanotherapy. This mainly means ultrasound and shock waves. So first, ultrasound. The idea of ultrasound is to simulate collagen synthesis and cell deviation. This has been proven in animal models, but not in humans up to now. So there is no evidence for the use of ultrasound in humans up to now. In contrast, the positive effect of shock waves has now been clearly proven. What kind of physiotherapy can help? Some positive effect of cryotherapy has been proven, but again, there is not enough evidence to give a general recommendation. And we have the same situation with friction massage. Here, the idea is that friction helps to restore elasticity of the tendon. A general recommendation for eccentric training can be given. This should be performed 2 times per day with 15 repetitions and 3 sets for about 12 weeks. So what is the theory behind eccentric training? It seems that with eccentric training, neovascularization and nerve sprouting is reduced, and that it preserves paratendon oxygen saturation. And so this training seems to improve collagen 1 production and so improves tendon strength via cross-linking and remodeling. So coming to the end of my lecture, I want to show you my way. For me, it's a multimodal approach, and patient education is a very essential part of this therapy. So here are the 3 team players: the patient, the physiotherapist, and the doctor. For the patient, I recommend ICE for some weeks. They should do eccentric training. I give them a bandage. I recommend sports break and then adaptation of the activity. If necessary, I give them a heel wedge for 6 weeks and I give them nitro. The physiotherapist is doing cryotherapy, eccentric training, friction massage, and if possible, treatment of underlying causes should be performed, for example, instability or flat foot. And I myself do extracorporeal shockwave therapy, and I'm also looking for treatment options of underlying causes. Looking at the therapy over time, I start in the acute phase with spots, pause, and nitro 2 times per day sprays. Then I recommend ice, and I give them a bandage with a heel wedge, and I start with shockwave therapy. In the subacute phase, which is about 2 to 6 weeks after initial therapy, they can again start with light activities depending on pain. They should still use nitro 2 times a day. I go on with shockwave therapy. They still wear a bandage, and if still painful, they still also use a heel wedge. Physiotherapy is now starting with extrinsic training, but also friction and cryotherapy, and they start with self-exercise, which mainly is eccentric training. When symptoms have disappeared at about 6 to 12 weeks after initial treatment, they start with progression of physical activity and depending on pain and tendon response. They go on with physiotherapy, especially eccentric training and also again friction, and they do self-exercises. And as a long-term prevention, I go for strengthening exercises, stretching programs. Sometimes they have to change their training approach and sometimes insoles are needed. But if they still have pain after 6 months of conservative treatment, I recommend surgery. And here I have very good results with this technique of minimal invasive stripping as described by Maffulli. So thank you very much, and now I'm happy to answer your questions.
Yes, hi everyone. My name is Kiriakos Daniilidis. I welcome you to this great online congress. Thank you very much for the invitation. Also to Professor Weisi, Professor Polzer, Professor Klos. Thank you very much to all the team. You do so every year a great job. As you can see, I'm very sorry not to be 100% live with you because I'm still working. I present you the conservative treatment of Insertion's tendinopathy of the Achilles tendon, and I do not have any conflict of interest to declare. Let's start with a clinical examination. Hopefully, most of the time you can see share the pictures and the videos with you. As you can see here, it's a typically posterior part of the distal part of the Achilles tendon, or the insertion of the distal part of the Achilles tendon or the calcaneus. We have here a big swallowing, also with a secondary bursa, which is infected by the chronic tendinopathy. And the first diagnostic tool which I use is of course the ultrasound, because it's quick, cheap, and gets fast results. And even in the ultrasound, you can see on the proximal part where you can see my small finger, you can see the reason for this tendinopathy. It's a posterior bone ossification on the distal part of the Achilles tendon. And here you can see also the X-rays. You see this big, huge osteophytes, in fact, of the chronicle malinsertion from the Achilles tendon. And also we have a secondary plantar fasciitis, which was not clinical relevant on the plantar part. Here you can see the fasciitis, and but this was not relevant. The main clinical aspect was the distal osteophyte, and on the here you can see also the swellness of the Achilles tendon. What I always do, we all of us should do, is like to examine, of course, if we have any foot deformities like flat foot, or we have like pathological angles, and but I mean, you know, all the things. Here's another example: a huge posterior osteophyte, which is we make also a DVD, a digital analysis. 1 second, so let's play. Yeah, perfect. And here you can see also the distal part again. It's a very big osteophyte, so you can imagine if you see in a second this rebuilds. If you see now the in that region, so you can imagine how painful is that. So in the first steps, if there was no conservative treatment, we start always also to do an MRI, like to see first how's the situation of the bone, and secondary, how is the situation with the tendon. Do we have maybe any small lesions like we have here in this picture? And you can see it. Sorry, here's another one. Here you can see now these white small incisions, and the sorry again here. Yeah, perfect. So we have the clinical aspect. We have pain at the posterior aspect of the Achilles tendon. We have doing an ultrasound. We have doing an X-ray. We have doing also an MRI to see how the tendon is, if it's affected from these osteophytes. And then the big question is how we start now with the therapy, which algorithm. My personal algorithm is first, the best also in the studies, is the stretching exercises. We do a lot of taping also in combination. It's always a combination of, there's no singular therapy. It's always like a multifactorial therapy of doing taping, of doing the extracorporeal shockwave therapy, doing different injections. And we go always from non-invasive to invasive therapy. And on the last, of course, injections with ACP or PRP. Hyaluron is always also used. I always do also radiation because it's very effective. You have some nice studies to present you later here. And of course, if everything failed, a surgery is the last thing we could recommend, like to avoid more pain. So for the stretching exercise, you know, it's known are these simple methods you can use in the daily work. I do recommend like doing it 3-5 times per day in different aspects, like where depends on how much time you can spend in your daily use. Then to use also taping, which is very effective. I do present some studies on it. And as I said before, the injection with this ACP therapy. And of course, the shockwave therapy, which is quite effective and excellent results, and it's nice, easy to perform, and you have no complications. So, which I told you before on the radiation, it's my personal favorite, because as you can see on the right picture, you have after 3 months till 6 months, you get more and more painless. So it's quite effective. It's easy to perform and nice results also. The PRP has got effectively same good results. It's also easy to use. The thing is, it's a little bit expensive. So not always for every patient to use. And but the results are also quite good. We do perform the PRP or ACP therapy like in the peritendinium under ultrasound, and then we affect. I'm doing from the PRP once. From the ACP, I used to do like 3-5 injections weekly, and then to wait about 6 to 12 weeks to see the results, and then go on with further therapy if it's needed or not. Here I have an ultrasound video so you can see, perfect, it's playing. So you can see how I performed this one. So at first, at the left side, you see the Achilles tendon, and right, you see the osteophyte. Now I'm going with a needle inside. You see the needle now, and now I'm putting the ACP on the point of the, here you can see now the needle and how the Achilles tendon is blowing up. And yeah, I think quite nice to see. And this one I'm doing, as I told before, from the ACP, I'm used to do like between 3 and 5 injections of the PRP, 1 injection, because it's a high dose PRP. And it's, you always have to tell the patient that at the beginning, it's a little bit painful for maybe 1 or 2 days, but then it's like flowing up, and they feel the effect of it. And yeah, quite effective and good therapy. The shockwave therapy, as I said before, is also excellent in results, also very easy to perform. And it's always a combination of different things, like also here it's described, because you never do only one. So you do physiotherapy also, you do like the tapes, you used to do the shockwave therapy, you used to do the ACP or the PRP therapy. And in 80%, there are some from the New England Journal studies, in 80% of the cases, it's patient is healed, but no one knows really what was exactly the main topic. Like you can say, okay, use only that one for 3 weeks, and then you will be like, it's like the last one who's going to do the therapy is like the big healer, and the other ones before, if they change the doctors, they don't perform so good. But most of the studies confirm that. In 80% of the cases, after 3-6 months, most of the patients are like really feeling good. They have no pain. So the combination of the shockwave therapy, start with the shockwave therapy, always with very important physiotherapy, like taping of the foot is also of the Achilles tendon, very important, like I showed in the pictures before. And then you can also do like the PRP, ACP, like starting with non-invasive. I mean, that's my algorithm tree. Everyone's doing a different thing. Why I'm doing that is because I will avoid like to have discussions. If I start, for example, with an invasive therapy like injections, like to have then discussions why they should affect, or maybe you can get an infection or something else, like a complication. And then you're always like in a difficult position to explain why you start with an invasive one. So I always start with a non-invasive, but I explain that also to the patients, starting with shockwave therapy, physiotherapy, doing a lot of taping, doing shockwave, the radiation, of course, and at least the injections of PRP, ACP, or hyaluron. It depends what is for the patient. Also easy to perform. Maybe they're for a little bit farther, they cannot come every week, so you do a PRP, or cannot perform and then shockwave therapy. That's a mixed culture. But in 80% of the cases, you saw the study from the New England Journal, all the cases are quite happy. In this 20, maybe 10%, then of course you have to think also about the surgery, and we have heard about the surgery, what is possible. So it's always an option. Thank you very much. Enjoy your time, and thank you being a part of it. Thank you very much.
Thank you, Professor Daniilidis. And we move on to Professor Polzer, and then we discuss together. Kiri, is this fine for you?
Yes, excellent. Thank you very much. I'm waiting, sir. Thank you.
Yeah. So, Hans, we would like to hear your post-op representation.
So finally, rehabilitation following operative treatment of Achilles tendon ruptures. The rupture of the Achilles tendon is a really severe injury. And I think during the course of time, we did make some advancements by introducing operative techniques. We were able to reduce the number of re-ruptures significantly, but at the cost of more wound complications. And several years ago, minimal invasive techniques were introduced to fix or to repair the acutely ruptured Achilles tendon. And this led to a significant reduction of wound complications without increasing the number of re-ruptures, meaning we were able to decrease complications, but it is as stable as we would do it openly. So this could be the end of the story, right? The re-rupture rate now is 2 to 4%, and we have a pretty low complication rate whenever we apply minimal invasive techniques. But as you can expect, it's not the end of the story, because the results are still often unsatisfactory. A lot of patients suffer a relevant reduction of the strength of the gastrocnemius soleus complex, about 30%. Only 70% of our patients are able to return to sports at all. And of those 70%, 50% have a reduced level of their sportive activity. So from my point of view, whenever we treat an acute Achilles tendon rupture operatively, it's not only about preventing a re-rupture or minimizing complication rates, but it's also about improving the function and the satisfaction of our patients. And there comes the rehabilitation into play. And I think it's a very, very important aspect. When we look at the reality in Germany, looking at this study, analyzed 213 protocols, post-operative protocols after repair of an Achilles tendon rupture. And none of these allowed immediate full weight bearing. And 6 weeks post-operatively, 77% still had a fixed immobilization of the ankle. And this is even more astonishing when taking into account that we have a large body of evidence, mainly deriving obviously from animal studies, but it all goes into the same direction, meaning that mechanical stimulation seems to improve tendon healing. This is what all the studies available suggest. So looking at rehabilitation, we have two main aspects. We have the weight-bearing aspect. We can have our patients full weight-bearing, partial weight-bearing, or non-weight-bearing. And the mobilization, full mobilization, partial mobilization, or immobilization. And these are the two aspects we can combine, obviously, right? So in 2022, we performed a systematic review and meta-analysis, and we were able to identify 20 prospective randomized controlled trials with more than 1,000 patients. And looking at the re-rupture rate, the full weight bearing and mobilization did not increase the re-rupture rate compared to non-weight bearing and immobilization. On the contrary, we saw a tendency toward a lower re-rupture rate when full weight bearing and mobilization was applied. The same was true for major complications. Major complications were not increased when we had our patients fully weight bearing immediately and mobilized when compared to non-weight bearing and immobilization. And you see the direction this is going. The same is true for minor complications. But we have to admit the studies were very heterogeneous, as usual in orthopedic surgery, unfortunately, and therefore we were unable to perform a quantitative analysis regarding return to work, regarding return to sport, and regarding to functional results. But again, the tendency was clear. We saw a faster return to work, faster return to sports, and a tendency towards better functional results. And to show you that we were not the only ones observing these results, this is an overview of all the meta-analysis and systematic reviews I know of, comparing restrictive aftercare versus functional aftercare following operative repair of an acute Achilles tendon ruptures. And you see that all these studies come to the same conclusion. All the studies recommend functional treatment following the operative repair. So taken together, we do not see an increase in re-rupture rate and complication rates whenever we apply a functional rehabilitation. We did not observe any inferior results, neither did the other studies. On the contrary, we saw significantly better patient satisfaction, and we saw a clear tendency for better functional results, faster return to work, and faster return to sports. So go for it. And this is our protocol. Very specifically, we have our patients full weight bearing immediately in a fixed plantar flexion of 30 degrees. Then we have the patients return for removal of the stitches after 2 weeks, and we change the settings of the boot. We still have them full weight bearing beginning week 3, but now we start to have them mobilized, a protected mobilization in the boot between 30 degrees plantar flex and 0 degrees. So yeah, and I would like to take the opportunity to invite you all to Munich in May 25. There will be more talks regarding Achilles tendon and many more things, and I would be very happy and honored to see you there. Thank you very much.
So thank you, Hans. Really important talk, because we're talking the whole day about functional therapy, and now you're telling us what is it? What is it exactly? So we have everybody there. We're going in with direct questions from the panel. The first question is, do you have any experience with percutaneous galvanic electrolysis therapy? Has anybody has experienced that? Galvanic therapy?
None whatsoever.
I'm sorry.
Faculty, is anybody of you using ice therapy in conservative treatment?
Not actually, me not. I don't know how's the experience with Matthias or Hans.
No, I don't.
Neither do I.
Some question. Okay. We go on. We go to Kajetan later. Matthias, what is your time frame to stop conservative and going to surgery? Or what do you do surgery in your patient in this?
Well, as I've mentioned in my talk, I do surgery in high-level athletes and in high-demand patients. And what I think it is also crucial to have a look, do they have the surroundings that allows them to go for proper functional treatment? Because if you look into the details there, it is a very detailed protocol. And if you do not follow that protocol, you'll result in a higher re-rupture rate. So that is also a very important decision maker. And the most important decision maker is the ultrasound. And if the rupture is older than 2 to 3 weeks, I tend to opt for surgery also.
We heard this already from Belgium. So they say about 2 weeks after that, they will go for surgery. Do you see the same view?
Yeah, but I'm not aware of any high-level evidence that supports this. So that is basically mainly a gut feeling. If ever it is a fresh rupture and I can decide the time frame when I'm going to surgery, I'll try to have them on the table in the first 72 hours.
Good. A question to Hans from the panel. Do you treat each patient with a dynamized Vacoped to allow range of motion, especially plantar flexion?
Yes. What patients are you thinking about? Which patients shouldn't I treat this way?
Your patient, you're after surgery. You do this in every patient, and my question is, what do you want to see or feel to start this? Is there any functional test you say, now it's the right time to start doing a functional therapy?
So we see them, we do this in basically every patient. In high-level athletes, we have a little different aftercare rehabilitation protocol. But what I want to see is that we didn't lose any plantar flex of the repair. And when I see that I'm losing plantar flex of the repair, I would be a little more taken back. If I see that I have still a good tension, then I start the protective range of motion in the boot. And I do it basically in every patient, yes.
Any questions from you? I would go with Professor Daniilidis. what is the difference in your therapy regime between a mid-portion and an insertional portion tendinopathy? You change something or you do something, you skip something?
Yeah, thank you. Yes, actually, in the mid-portion tendinopathy, the shockwave therapy is not so successful because I think you don't have such good angiogenesis of the tendons. So the ACP therapy makes more sense. If it's more distal to the bone or more proximally to the gastrocnemius in the musculotendinous part, there's more senseful. That's the philosophy on it.
Okay, interesting. We will have later Karsten Knobloch. We will ask him again. Nice.
I'm sure.
Great thoughts as usual. Hans, especially, if you have already repaired your Achilles, okay? So would you still go, you say you would still use the same functional therapy. Would it make a difference where you start from? Would you start from plantar flexion position? Would you start from neutral? Do you think surgery would enhance that first 4 weeks perhaps in your regimen?
So just to get your, make sure I got your question right. You're asking whether the amount of plantar flex I reach during the surgery, whether this does affect the aftercare. Did I get the question right?
Yeah, in a way, but does the surgery itself, because knowing that you have reattached the tendon in a certain way, whatever technique you're using, would that change your protocol of functional rehabilitation, but post a surgical repair?
Mm-hmm. We started off when we did the we started off that we cleaned both legs and we tried to adapt the plantar flex we want to reach to the unaffected leg. We changed this because we saw that we regularly lose a little bit of the plantar flex over time, and therefore now we aim for the max of plantar flex, so to say. So I always start with 30 degrees of plantar flex and I try to over tighten it a little bit to the other side. And in order to reduce the amount we lose of plantar flex, we also adapted the surgical technique. We do a transcalcaneal drilling now, and we put the stitches percutaneously transcalcaneal to avoid the lengthening, and we increase the cut on the proximal end a little bit. We are using the Dresden instrument. I do now an incision of 2 to 3 centimeters, and I do some Krakow stitches at the top in order to reduce the lengthening of the repair. And I over tighten it a little bit, and therefore I start with 30 degrees.
We have one question on the panel. Do you see any increase in treatment period while treating the patient functional? So it's shorter. And does this shorten of healing period of you view similar to immobilizing treatment? Is it the difference between immobilizing and functional? It's a shorter post-op time? For you, Hans?
I don't think it is shorter. I just think the result is different.
Okay. So
you start to move quicker, of course, but you know, if you see the return to sports or the return to competition, it is not necessarily quicker. And if you look into detail into these functional treatment regimens, most of them don't allow any dorsiflexion whatsoever for 4 to 6 weeks. So that's not real quick.
I fully agree. The return to work is much quicker. With this boot, you can ambulate without crutches after beginning week 3. So people are able to return to work much quicker. But I fully agree with you, Matthias. The return to sports and the final result, this takes still a lot of time. And we do know from the studies, looking now at professional sportsmen, that it takes more than 1 year to get the final result strength-wise. And this is probably not changed by the functional rehabilitation. But looking at a normal person like us, I would say, you are much quicker back into everyday life, much quicker back into work, and into daily activity. This yes, but the final result, full strength, this takes a lot of time, and this is probably not effective.
There's one other question.
So that brings me to my next question, because I was just about to ask Matthias, because obviously you say you use the SMART protocol for functional rehab, right? And if you look at in that protocol, sports is practically forbidden till the 9th month, almost. So why would you think that an issue?
Sorry, I can't hear anything now because there's quite loud noise.
Okay.
Okay.
Now I can hear.
Now it's okay?
No, I'm not muted.
Okay.
No,
I think
I'm not muted.
I think it's Kajetan.
I think Kajetan is now demuted.
You don't want to hear.
He's back.
No, we want to hear you, Kajetan, but now it's the Matthias' turn. Don't be upset. Don't be upset, Kajetan. So again, a question for Matthias.
Or Kajetan.
No, it's not.
Okay, Matthias, you say you use the SMART protocol, and when you're doing the functional therapy,
I try again. Do you
Kajetan, it's not your turn.
hear me?
Sorry.
Okay, Matthias,
last question.
One last time. When using the SMART protocol,
sorry.
It's okay. When using the SMART protocol, you almost would never return a person to sports. And I mean actual playing sports, not just walking around or doing recreational sports for 9 months, right? So that's in the protocol. Why would you think that would be different post-surgical? So why is it that you have these NBA, NFL, professional football players? If you actually propose that to them, and this is why you're probably going to surgery, right? In these group, but they also return. Okay, you're shaking your head. Go ahead.
I don't think that they're going to return any earlier, but they're going to be better if they opt for surgery. Have a look into how quick David Beckham returned after his Achilles surgery. And if I recall properly, it was 9.5 months. So I think this is basically a realistic time. And if you look into literature, you can consider yourself lucky if you come back at NBA or NFL or professional football at your same level after Achilles tendon rupture. So I think it's not mainly a question of time, but a question of function.
Okay. Thank you all. Thank you. We really appreciate your talks. And we have one chat question. We will discuss this after the French session. So we move on to France. But Guillaume is...
Thank you, guys.
Thanks, guys. Thanks, guys.
Thank you. Thank you very much.
Thank you. Bye-bye.
Thank you.
Hi, everybody. First of all, I want to thank Azi for his kind invitation. And for sure, big thank to the OPED company for the support of this crazy event. So I will introduce the French session. And the team of surgeons will present this afternoon the results of the symposium of the French Arthroscopic Society. The topic was about Achilles pathology treatment, and the goal was to compare the results of open and arthroscopic techniques. The first speaker will be Olivier Barbier from Toulon, and he will speak about tendinopathy or midportion pathology.
Hello, thank you very much for your invitation. And very happy to speak about the result of our symposium by the Francophone Arthroscopic Society on corporal tendinopathy of the calcaneal tendon. Achilles tendinopathy commonly affects competitive and recreational athletes as well as sedentary individuals. Approximately 0.2% of the general population and up to 9% of recreational runners could suffer from Achilles tendinopathy, and there is risk factor like aging, overuse, obesity, diabetes, steroid, statin, or quinolone. It's a tendon degeneration with damage, weak and inelastic tendon issue result from a failed healing response, which may cause this degenerative change in the tendon. And when conservative treatment fails, in 25% of cases of patients, surgical option may be pursued. In a previous symposium in 2008, the Francophone Arthroscopy Society do a retrospective study of 82 patients after open surgery with 90% of excellent and good result and 75% of patients who were satisfied and a return to sport at 6 months average. History of endoscopy in non-national Achilles tendinopathy is very recent. Open surgery was described by Thiounn in 1987, and the first description of endoscopy was by Nick van Dijk in 1907. After, there is two description of technique with Maritz described tendinoscopy with a peritendinous debridement with a proximal portal for visualization and a distal portal for instruments. And after, Vega described a percutaneous approach with an arthroscope in a distal portal to perform anterograde longitudinal tenotomy under visual control, and with instrument in this technique in the same trocar as the arthroscope. So actually there is two solutions for surgery: open surgery with an open debridement, longitudinal tenotomy and peritenolysis, and endoscopy technique who consists of a debridement of the tendon, longitudinal tenotomy percutaneous, a peritenolysis, and in most of cases a plantaris excision. The objective of our study and symposium was to compare functional results and return to sport of endoscopy and open surgery in this indication of corporeal tendinopathy of the calcaneal tendon. A multicenter, prospective, comparative, non-randomized study was made during 24 months. Inclusion criteria were corporeal tendinopathy of the calcaneal tendon with conservative treatment fails after 6 months. Demographic data, type of sport, scores like AFAS and VISA at 6 weeks, 3 months, 6 months and 12 months were noted, and an MRI was realized at 6 months to evaluate the cicatrizations of the tendon. Both the result of our study, 60 patients were included in this prospective study, with 1/3 in the endoscopic cohort and 2/3 of patients in the open surgery cohort. These two cohorts, there is no significant difference between these patients in age, sex ratio, weight, and sport activity. The only difference was the plantaris inflammation. It was more important in the endoscopy study. When we are looking for the type of surgery, we can see there is a difference of technique. With endoscopy surgery, there is more synovectomy and plantar tenotomy, unlike with open surgery, there is more only debridement. For postoperative care, there is no significant difference with immobilizations during 3 weeks on average, and a discharge was less important with arthroscopic technique, but without any significant difference. there is no complication in our study. As is concerned post-operative data, we can see here the functional score at 3 months, 6 months, and 12 months. We can see there is a real benefit from 3 months up to 12 months. So results are more and more better with on the first year. But there is no significant difference between open and endoscopic surgery. There is no complication in our study. As is concerned, the return to sport, we can see there is no difference between open and endoscopic surgery, with an average of 60% of patients return to sport at 3 months, 80% at 6 months, and more than 90% at 2 months. But the return to sport at the same level is less important, with at 6 months only 1/3 of our patients return to sport at the same level. So, as a discussion, we can see with our study that there is a real benefits and good result of surgery from 3 months to 12 months. And the return to sport at 6 months concern 90% of patients, but this return to sport at the same level is more important, with only 1/3 of patients at 6 months and 2/3 at 1 year, with no difference between endoscopy and open surgery. In literature, the first literature review report the result of the first description of this technique by Macaron and Van Dyck and Maffulli, with excellent result most of the time. More recently, in 2070, there is a review that compare all the technique: open surgery, minimal invasive surgery, and endoscopic surgery. 11 studies describe the outcome of open surgical approach with large variations of technique. None of these studies reported on patient satisfaction and report most the complication. It range from 0 up to 90%, and a success rate varied from 70 to 100% of patients. For minimal invasive procedure, 7 studies were included, with general release of the Achilles tendon, and patient satisfaction was the same as open surgery. 3 studies report the outcome of endoscopic procedure with debridement of the peritoneal and additional release of the plantar Achilles tendon, and a very low rate of complications, 0 to 7%, and the success rate was the same as open surgery, so 70 to 100% of satisfaction and success rate. The last review in 2023 include 46 studies. This is a fair evidence in this conclusion of this paper in support of open debridement and arthroscopic and minimally invasive technique. This is poor evidence in support associated technique like FHL transfer, longitudinal tenotomy, peritonealis, gastrocnemius recession, or plantaris excision, and there is insufficient evidence to provide any recommendation regarding other surgical treatment methods. We can see all the study of open debridement, with the highest quality study was a level 2 study by Maritz, who include only 36 patients with a good result. Only other study were case control study or a retrospective study. Concerning minimal invasive endoscopic surgery, there is no level 2 study for endoscopic and only level 4 or level 5 study. So as a conclusion, we can see this study is the first level 2 study about comparing open and endoscopic surgery. This is the largest prospective comparative study in the literature, and we can see that this surgery offers good functional result with no difference between open and endoscopic technique. There is few complications, and the return to sport is more than 90% at 12 months, but only 2/3 at the same level. Thank you very much for your invitation, and now I can invite you to our Congress in Nantes in December. Best regards.
Okay, thank you to Olivier for the presentation of this first part. My presentation will focus on calcaneoplasty for Haglunds disease. So first, Olivier presented the mid-substance tendinopathy results of our symposium. I will discuss about insertional tendinopathy results on a global view and then focus on calcaneoplasty. And in the third part of our presentation, Alexis Thiounn from Lille will discuss calcaneoplasty and reinforcement and reattachment after detachment. And then he will conclude. So our symposium include in the total 359 patients, and for insertional tendinopathy, we analyzed 276 patients with a little bit less than 150 for endoscopic treatment and more than 100 patients for the open surgery. The patients of the cohort come from different centers in France, from all over the country, and more than 17 surgeons were implicated. So if we consider the lesion we treat, we can see that with endoscopy we treated higher grade of lesion due to MRI assessment. About anesthesia, the local regional anesthesia was more frequently used with endoscopy treatment, probably because the team that use endoscopy to treat tendinopathy are more on the sports side, and the anesthetists are more with a new technique, and they use more frequently local regional anesthesia. What about surgical duration? If we consider all the techniques to treat insertional tendinopathy, technique was faster with open surgery, and we found no significant difference about complication. The immobilization time and non-weight bearing period was shorter with endoscopic treatment. About back to work, it was more frequent during the first post-operative consultation with endoscopic treatment. And at 3 months post-op, we found higher scores with endoscopy technique. But at 3 months, no more difference between the two techniques about the work, but still better score with endoscopy treatment. What about the 6 month follow-up? We made MRI to control the lesion healing, and finally we find no difference between the two groups. No more difference between the criteria of work showing discomfort or return to sport. And the score was still higher with endoscopy. At 1 year post-op, only the score with the A was higher with endoscopy. Now, if we focus on the calcaneoplasty technique, so we had 36 cases of open technique and more than 50 cases with endoscopy technique. So the technique used was very classic. 2 portal, we use the shaver to remove the posterior superior part of the calcaneus, and we control to remove the bone until the tendon insertion. For the calcaneoplasty, surgical time is lower, so the technique is faster with the endoscopy. And you can see for the post-op protocol, the immobilization time was 2 times shorter with endoscopy than with open surgery. And the weight bearing was immediately authorized with the endoscopic technique. So the work was quite normally after endoscopic treatment at 1 month post-op. And patients required two more times after open surgery to work normally. About back to spoke, it was more frequent and with superior level in case of endoscopy, but we didn't find a significant difference about the functional scores. At 6 months, no significant difference for the scores except for EFAS score, that was higher for the endoscopy technique. At 6 months, no more difference about the work and the sport. No difference during MRI post-op assessment of the tendon lesion. And at 12 months, no more difference. So finally, what we can say to our patient when we treat it with the endoscopy. Yes, rehabilitation is faster with endoscopy. So work is faster at the first consultation, 1 month post-op. Return to sport is more frequent at 3 months post-op, but from 6 months post-op, there is no more difference. So the results are published in the orthopedic traumatology research. And I thank you for your attention. And now we will have the presentation of Alexis Thiounn for the other technique of treatment of insertional tendinopathy. Thank you.
Hello everyone, thank you to the organizers of this Congress and to Guillaume Cordier for the invitation. So a real pleasure for me to talk to you about the calcaneoplasty and suture augmentation for enthesopathy. I'll show you some innovations and arthroscopic techniques, and I'll give you the results of our symposium of the SFA. So we saw with my colleagues the main objective of this symposium was to compare arthroscopic and open surgery for the midportion and an insertional Achilles tendinopathy. For insertional tendinopathy, we have classical open surgical techniques. We have to use the calcaneoplasty with or without reinforcement if we have tendon lesion or disease. We use the Zadek osteotomy, and we use the detachment and reattachment of the tendon when we have to remove enthesophyte and do a complete calcaneoplasty, and after an reattachment of the tendon. All these techniques can be associated with procedures, fascial transfer, proximal or distal gastrocnemius lengthening. For the arthroscopic surgical techniques, we have, as we saw with Guillaume Cordier, the isolated calcaneoplasty. And I show you the calcaneoplasty with reinforcement with a single row of anchors, and the complete calcaneoplasty which used to detach and reattach after the tendon. All these procedures can be also associated with fascial transfer or gastrocnemius lengthening. For the calcanoplasty with reinforcement, as you can see, after your complete calcanoplasty, like if it's isolated, if you can see some disease, some detachment of the anterior part of the tendon, you can reinforce it with a single row of 2 anchors and 1 tape. And as you can see, the tendon is after reattached for the anterior part to the calcaneum. But if we have to remove, for example, the antezophyte or to reattach the tendon because there is a lot of lesion or detachment due to the disease, we can detach and reattach the tendon. So it's a common technique and open procedure. And from 2029, it has been described by Dr. Boniface in Annecy. So the technique in the video, you can see 2 classical portals for the calcaneoplasty. And when it's complete, we add 3 more distal portals in order to be under the skin and upside the tendon and the antezophyte. So we do a complete synovectomy, and after we start the burning of the antezophyte, and after, as you can see, the tendon is progressively detached, and at the mid portion you can see like a cuff rotator of the shoulder, all the tendon detached at the end of the calcaneoplasty. So after we do a reattachment, so 2 ankles at the first row with tapes, and the tapes are passed through the tendon with a suture lasso. After the tapes are crossed under the skin, and we proceed to the reattachment with a second row of anchors, like this. And as you can see on this picture, it's the same results like an open surgery technique. We can associate it with an fascial transfer. For me, I prefer a transfer with an horizontal calcaneal tunnel. So for our study, all the inclusions are based on the usual indication of the center. It was this follow-up, so 12 months at the last follow-up. We use to evaluate the patient before and after surgery X-rays, bearing stitch X-rays, in order to calculate the length and the pitch of the calcaneal. And we propose MRI classification for antezopathy. It was between stage 1 and 5. The stage 1 was just bursitis. Stage 2, intravenous tendinous fissuring. And we have stage 3, 4, 5 for progressively detachment of the tendon. For evaluation, we use 2 functional scores, the FAS and the VISEI. At the results of the inclusions for all the tendinopathy, we have more than 340 patients included between all the centers in France. For the demographic data, we saw that more men and more recreational athletes or runners. For all the techniques, there was a few complications, only 3.15%. For all the techniques, there was only 13% of associated procedure. There was more proximal gastrocnemius lengthening, and it was more for the arthroscopic techniques. So now, if we focus on the insertional tendinopathy results, we had 277 patients included. For all patients, we have functional improvement from 3 months. If we compare all the techniques, there is an homogeneous distribution of techniques between isolated calcaneoplasty with reinforcement or a detachment and reattachment of the tendon. We had a faster return to working and sport with arthroscopic technique, but no functional difference at 6 and 12 months, so only an early advantage for the arthroscopic technique. If we focus on the calcaneoplasty with reinforcement technique, we have a longer procedure time with arthroscopy, but a shorter offloading immobilization for the arthroscopy, faster return to working to arthroscopy, and better functional scores at 3, 6, and 12 months. So we have an advantage here for the arthroscopy. If we focus on the detachment and reattachment technique, we have longer procedure time with arthroscopy, but here we have also a shorter offloading period with arthroscopy, so a faster return to work and sports with arthroscopy. Higher functional score at 3 and 6 months, but no functional difference at 12 months, so only an early advantage for the arthroscopy. If we compare only the 26 patients who had Zadek technique to all the others, we saw an immobilization and offloading longer for the Zadek, so an earlier return to work and sport for the non-Zadek technique. But it's interesting to see that there was no difference at 12 months. So only an early advantage for the no-Zadek technique. If we do again the match between Zadek and non-Zadek osteotomy, we have a little bit better correction of the length of the calcaneal for the Zadek osteotomy, but a better duration of immobilization and offloading for the non-Zadek technique, a better return to sport and working for the non-Zadek technique, better functional score at the beginning, but no difference at 12 months, and maybe because we have no literature for the non-Zadek technique, long-term outcomes for the Zadek technique. I think we have to reevaluate this comparison, maybe with percutaneous technique. If we turn to insertional tendinopathy with the other techniques, so if we compare the 3 techniques, we saw that for the isolated calcaneoplasty, we have MRI stage at 1 and 2, so the lesion were better for this technique, and we had detachment of the tendon, so stage 3 and 4 for the reinforcement and the detachment and reattachment of the tendon. Because we remove antezophyte and calcification for the detachment and reattachment, we don't see after the surgery X-rays antezophyte. We saw that in isolated calcaneoplasty, some antezophyte were ignored. So we do the sub-analysis of the results for the needing of remove all the antezophyte, and if there were no pain at the antezophyte before the surgery, there is no difference at the end. Functional scores were better for the isolated calcaneoplasty at 3 and 6 months, but no difference after 12 months. So if we do some recommendation for the insertional tendinopathy treatment, if we have MRA stage 1 and 2 and no pain on the antezophyte, we can do isolated calcaneoplasty. If we have stage 3, 4 MRI stage with antizophyte and distal pain, we have to do a detachment, reattachment. But if we don't have, we can do an isolated calcaneoplasty with reinforcement with a single row of anchors. If you need a rapid return to walking, the arthroscopy technique will be better for the isolated calcaneoplasty, but at the long term, no difference. For the detachment, reattachment, an earlier advantage for the arthroscopy, but at the long term, no difference. But for the calcaneoplasty with reinforcement, there is an advantage for the arthroscopy. So if we have key takeaways from this symposium, it's the largest prospective comparative series in the literature. The surgery provides good functional outcomes with arthroscopic or non-arthroscopic techniques. There is few complications. There is faster return to working and sports due to arthroscopy, but identical functional outcomes at 12 months. The limitations here are the follow-up. The free shelf of indications show a center effect. The MRI classifications is not yet validated, and we have a learning curve for the arthroscopic technique. But we have good perspectives. We'll reevaluate all the series at medium and long term with the functional scores. Merci beaucoup.
Okay, thank you very much, Alexis. So, do you have some question?
We have a question from the panel. You can. No, you
Yes, it's about the indication finally for the treatment of open Haglunds disease. So the question was, is there any role for central tendon split approach, retrocalcaneal bursa excision, Haglund excision, and Achilles repair with suture anchor? Yes, for sure, there is. This is the conclusion of the symposium. There is still this kind of indication. If there is a Haglund disease and enthesopathy, so if there is just an impingement between the tendon and the posterior part of the calcaneus, you can just perform a calcaneoplasty. You can do that open or arthroscopically. And if there is enthesopathy, one of the treatment could be to detach the tendon. So you can use this approach and to reattach using a suture anchor. The fact is there is some study in the literature, but this is the first and so large study. It was a multi-center prospective study comparing open and arthroscopic. Because for many indications, we are thinking about the advantages of arthroscopic versus open surgery, but frequently it's not really demonstrated. And then after this symposium, we can conclude that at 12 months, we don't highlight difference between the two techniques, but until 6 months, there is a faster recovery for the arthroscopic technique. So the answer of your question is, for sure, there is still indication for open surgery, but if you practice endoscopy, you will have faster results.
The follow-up to the question was that you're not changing any biomechanics, so they are asking, isn't it a possibility that you're just treating the pathology and then it will recur?
We change exactly the same biomechanics as with open surgery. So the problem is the indication between the calcaneoplasty and the calcaneoplasty with the detachment and reattachments. But it's the same question with open and arthroscopic surgery.
And also in the same patient, you can find the patient has a bilateral disease and he's only complaining or she's only complaining of one side, although on the radiographs they are normal. They are, equivocal. So I'm not sure about the pathophysiology that in the end causes that tendon to be painful and the other side not.
But we were talking about this before. Maybe the shortening of this posterior chain, or maybe the Achilles tendon on its own, is the major problem. So should we do a lengthening associated with such a distal procedure, or should we do only a lengthening and no distal procedure? This would be interesting studies to do.
It's exact. And when we perform this technique, once again, open or endoscopic technique, sometimes we just detach partially the tendon, so we don't change something on the mechanical or biomechanical side.
Yes.
And the question is, do we need to lengthening? Is it a problem to shortening when we suture the tendon on the calcaneus? And we don't have still the answer.
What would be the indication for lengthening a gastro release? Let's say silver scale test.
Yes.
10 degrees maybe, or 0 degrees?
Yeah,
for fully knee extension.
It depends of the knee position. So if you don't have dorsal flexion, with extension of the knee, you have to lengthening gastrocnemius, and this is the first
0 degrees, 10 degrees. Normally it's up to 30. But
we consider 0 degree. In Bordeaux with Pierre Baroque, 0 degree.
That's one. Okay.
Yes. And then this is a first line treatment, for sure is not a distal treatment, is a treatment of lengthening. And it could be a good option when we have a bilateral pain.
Yeah.
Because probably there is a biomechanical problem when it's bilateral.
Yeah. Have you done the surgery altogether, gastro release plus Haglund endoscopy?
No, never, because I think if you have to do the lengthening, this is a first line treatment without
maybe do the proximal surgery and wait.
It's the same when you perform the Zadek osteotomy. Normally you don't perform something on the anthesitis site.
But maybe you have a very shortened patient even with a pain in Haglund, so you have a mixed symptom.
Yes, but normally if you lengthen the posterior chain,
you can have that patient.
You will treat also the pain of Haglund.
Perfect. Thank you. We will go on this. You're not out with this whole discussion. I have a lot of questions still, but we are honored. We have right now Professor Maffulli with us. So I don't want, and we don't want to leave him waiting for us. So we are honored to have Professor Maffulli with us, and anybody who has any time heard something about Achilles tendon will know him very well. And now we are honored to have him live with us. Could we bring him in? No, this is not Professor Maffulli. This is Karsten. Hello, Karsten. So we are.
Sorry, I cannot see anybody. Can I?
Professor Maffulli, we can see you very well. We are really honored to have you with us. I heard you have a little flu, and especially honor and thank you for being with us.
Pleasure. It is a great pleasure to be here, and thank you very much for having invited me. I'm also very grateful to my old friend, Karsten Knobloch, because he was supposed to be next, but unfortunately, I have not seen my family for a whole week, so family calls. Okay, so Karsten has allowed me to go before him. Karsten, my thanks to you.
Thank you. So the floor is yours. We will still have questions afterward, but we will.
Okay, so we can have questions immediately afterwards, but I cannot stay for long afterwards. Is it okay?
That's perfect. That's perfect for us, and we are honored. And the floor is yours. Your presentation.
Thank you very much. It is, as I say, it is a great honor to be able to share with you some of my ideas. I was given free rein on what to talk about, and I decided to dwell a bit more on chronic Achilles tendon tears, simply because we are seeing more and more of these, especially in the UK. And in the UK, we are seeing a lot of patients who have had conservative management of Achilles tendon tears, which have not healed, and therefore they then come over to see me with massive problems, with several months down the line, with a leg which is pencil thin with muscles which are totally atrophic and so on. So I would like to tell you something about our feelings about chronic Achilles tendon tears. And at this point, I would like to thank the whole team. I am now at Sapienza University in Rome, but I've been at the University of Salerno before moving there, and this is the group at the University of Salerno. Together, we got a big grant from Horizon 2020. We call the P4 Fit. So we had a multi-center studies, basic sciences mainly, where we looked at many aspects of tendon tissue engineering and so on. Francesco Oliva, Professor Francesco Oliva, who some of you may have met, was my associate professor in Salerno, but he's become the chair of orthopedics at San Raffaele University in Rome. So as destiny will have, both of us are in Rome now. And this is Professor Della Porta, who is a basic scientist who's been working with us for the past 10 years or so. Also, we have the University of Bologna on board, and Keele University, one of my old universities where I was a chair in orthopedics in the early part of the century. Professor Nick Forsyth has left the University of Keele and is now the Pro-Vice Chancellor for Research at the University of Aberdeen. We also have commercial collaborators with NovaGenet, and without them we would not have been able to undertake some of this research. Now, when we talk about chronic ruptures, we should know that there is a different definition according to which side of the Atlantic you are on. In Europe, we think that a chronic tear is a tear which dates back 6 weeks. In the States, only 4 weeks. This may have implications because we have shown in a study published in the American Journal of Sports Medicine a couple of years ago that you can still undertake a primary percutaneous repair up to 4 weeks from the injury. So it may be that by that time, by 4 weeks, is just not old enough the tear to be declared a chronic tear. Are these common injuries? Oh, well, let me tell you, they are. Below the age of 60, 20 to 25% of patients are not diagnosed properly. And above the age of 60, 1/3 of patients are not diagnosed straight away. And this figure, the 33%, is coming from Sweden. So a first world country with a great healthcare system, great surgeons, and nevertheless 1 in 3 patients are not diagnosed straight away. There's no sorry. There's no doubt that diagnosis is more difficult than in acute ruptures, and the management is technically more demanding than primary repair. If you think about the tendon stumps are retracted and atrophic, and the surrounding tissue status is equally atrophic, and if you then impose your surgery onto these tissues, then it would not be uncommon to have major problems and major infections. The diagnosis, however, is clinical. And from a purely clinical viewpoint, you can see the difference between this leg and this one. So this is the Maitland's test, the knee flexion test, where it's a no-touch test. You don't touch the actual Achilles tendon, but you can see that as the Achilles tendon is gone, the foot drops and therefore stands at a more acute angle than the normal contralateral one. Obviously, the calf squeeze test should also be positive, but if the tendon has tried to heal and it has had adherences to surrounding tissues, it may well be that you may get some motion when you undertake the test. MRI and ultrasound are not an absolute necessity unless you undertake research. Obviously, I work in teaching hospitals. I've always worked in teaching hospitals, and we undertake a lot of research, and therefore just about all our patients have undergone some form of more advanced imaging. I'm blessed to have an absolutely exceptional interventional radiologist, Otto Chan, who is a magician with the ultrasound, and so we now use ultrasound as our very first line advanced imaging technique. But please collect the history and use the old orthopedic adage of look, feel, and move, and examine the patients. As I said, operative procedures are more technically demanding. There are several papers which describe end-to-end sutures. This can be undertaken, and indeed, if you manage to do that, it could be all you need. Turn-down flaps with 1 or 2 flaps have been described since at least the late 50s. They work. They are invasive, however, and they use, if you think about it, they use second choice tendon, second choice tissue to try and recreate a normal tendon. It is a second choice tissue because we have shown very clearly in the last part of the 20th century that the whole of the tendon, even the one that macroscopically looks fine and it's far away from the rupture site, is histologically and from a molecular biology viewpoint, gene expression and so on, altered. So I like using local tendons or autologous free tendon grafts. In the States, allografts are very much on everybody's mouth. We in Europe are probably a lot less cavalier in the use of allograft. They are expensive. We don't get hold of them so easily. And if you have good local tissues, I don't see why you should use allografts. Indeed, I never used one to reconstruct an Achilles tendon. If you undertake this kind of surgery, expect complications. And the classical ones are wound breakdown and infections. Unfortunately, nobody sees enough of these patients to be able to undertake a randomized controlled trials. And therefore, there are relatively small studies. There is no gold standard in this field. I'm sorry, can I interrupt a second to get some water? Thank you for your patience. There are many techniques and available, and the first one I would like to talk to you about is peroneus brevis transfer. It was first described in the modern literature in 1974 by Perestroifer, but in reality it was proposed much earlier by White in 1949. White published this paper on the 1001 uses for peroneus brevis and published in a journal now extinct called Journal of Obstetrics and Gynecology and Surgery. And it can be successfully used in patients with large defect. It is a personal favorite of mine. As you can see here, I've used a medial approach to the Achilles tendon, and I've harvested the peroneus brevis through a medial approach. It's a personal favorite of mine because my boss and my mentor, John King, learned it when he was a fellow with Ilia, and then he communicated it to me. We have done a lot of stuff in that respect. We have published the first paper in 2001, and 10 years later we published the long-term follow-up. As you can see, it's from the previous picture, it's a great tendon, nice muscle belly, but it requires long incisions and high risk, obviously, for infections. And indeed, these are all my patients in whom this technique has been used. So you can see the infections here, and eventually all of these will heal, but it takes a long while. If you ever undertake this kind of surgery and you have these infections, don't worry too much and just continue to follow the patients up. Don't send them over to your plastic surgeon's colleagues. Karsten, sorry for this, because many of them have not, they want to do things such as flaps and so on. It's just not worthwhile. Eventually, things will happen. So as the incisions were so big, we described a 3-incision peroneus brevis graft use. We undertake an incision 2 centimeters proximal and just medial to the proximal stump, another distal and lateral at the bottom end of the rupture just around the calcaneus, and another 2 centimeter incision at the base of the 5th metatarsal. And in this way, you can use the graft and you can do things. One thing that we discovered talking to some of our arthroscopy colleagues, and I refer to Derek Cloy over in Hong Kong, is that you may well improve function without restoring the anatomical continuity of the Achilles tendon. And this is the case, then you don't need to have long harvests because you don't need to bridge the gap. We looked at these things, and we did a 2-incision minimal invasive peroneus tendon graft. We evolved from the 3-incision. We just made 1 distal incision at lateral and 1 incision over the base of the 5th metatarsal. We harvested the tendon, and the tendon is pulled distally. We remove the vincula that may be present, repair it, and we drill a tunnel in the calcaneus, and we shuttle the tendon through the calcaneal tunnel, and we fix it with an interference screw. Easily done. It's a bit fidgety, obviously, because you're working through small incisions, but it's very rewarding eventually. We also use an ipsilateral free semi-nervoso graft with interference screw fixation. We started dabbling with the use of ipsilateral gracilis and semitendinosus around 1995-1996, and we looked at large incisions and so on, and again we evolved from there. So the tendon, the ipsilateral gracilis or semitendinosus, is easy to harvest, but it can lead to the weakness of sprinting and deep flexion in the early phase of rehabilitation. But please remember that these tendons are used routinely for ACL reconstruction, and in 70% of patients they degenerate by 8 to 12 months from the harvest. We harvest the tendon from the popliteal fossa, not from the pes canceranus. It is very superficial. This is the nice depiction of the ipsilateral semitendinosus tendon. We harvest and use it as a free graft. We make an incision proximal and medial and distal and lateral. We expose the tendon. We don't necessarily expose the tendon defect, but we want to have a look at the distal and proximal tendon stumps and at the superior posterolateral corner of the calcaneus. This is the original technique whereby we're delivering the proximal stump from the medial and proximal wound, and we're freshening it up. And this is the distal wound. You can see here the posterolateral corner of the calcaneus. We normally make a small osteotomy so that there's no impingement of the harvested tendon, engrafted tendon with the calcaneus, and we stay very, very close in this way to the insertion of the original Achilles tendon of the calcaneus. We drill the tunnel from dorsal to plantar 45 degrees using a cannulated reamer, and this is what it looks like. So we pass the semitendinosus tendon transversely to the proximal end. We obviously suture it at the end, at the edge and exit point using an absorbable sutures, and then we shuttle it down. We pass it anterior to the tendon in the Kages fat, and we shuttle it down to the tunnel in the calcaneus in a standard fashion really. We use it in patients who have large gaps and allows this proximal and distal tendon stumps mobilization and restores the continuity and length of the Achilles tendon. The isometric plantar flexion strength recovers nicely, even though in the long-term studies we always find a side-to-side difference when we test patients with the dynamometer, and even though the difference is statistically significant, there is of no clinical relevance because the patients have returned to running, hopping, jumping without problems. In this way, there is no loss of functional toe plantar flexion or reversion, which is associated with local tendon transfer, such as flexor digitorum longus, flexor lucis longus, and peroneus brevis transfer. One myth that I would like to dispel at present is the fact that peroneus brevis transfer induces a significant loss of an eversion strength. This is, if you read the original paper where this was described, it dates back now about 40 years, and Jon Carlson wrote his PhD thesis on this. He states that there is a loss of 10% in eversion strength. 10% again could be statistically significant, but not necessarily clinically relevant. So it's not a big problem. I don't use flexor digitorum longus, but it has been described by Roger Mann, and Liu Shon has published a small series on this. Flexor lucis longus, especially in the States, has become very much a workhorse. I don't particularly like it, especially in athletic patients, because they need to be able to grasp the floor and propel themselves forward. It is true that there is no difference which has been described in the relevant studies, but it may transform somebody who was an absolute star striker in one of the many. Also, we've shown that in biomechanical studies performed with Bill Walsh in Sydney, we have shown very clearly that the two tendons are essentially equivalent in terms of biomechanical characteristics. Flexor lucis longus, nevertheless, is strong, is long, it allows to bridge large gaps, and it allegedly supplements strength exerted by the axis soleus complex. I say allegedly because if you think about it, the gastrocnemius soleus are the strongest muscle of the posterior aspect of the leg, and their strength is quantified, let's say, at 100. The FHL is the second strongest of that lot, and its strength is only about 10% of the strength of the gastrocnemius soleus complex. Therefore, even if everything goes well and if patients restore totally well their strength, Robert Jones showed at the just after the Second World War that just after the First World War, that when you were transferring a tendon, the muscle lost 1 grade MRC strength. So in reality, FHL doesn't work as a motor, it works more as a scaffold. As I told you, I don't use this eco-structure in running any sporting athletes because I like them to be able to grip the ground in a powerful fashion. And there is loss of flexion, obviously, on the interphalangeal joint of the hallux, which would be detrimental to their performance. But it can be done. I do it. It's a single incision technique. I use a 2.5 to 3 centimeter distal longitudinal medial para-Achilles incision. The dissect is John Lees. You just go down and you will find the tendon. You can do a short harvest, and then it all proceeds as per usual with a bit pin drilled in anterior direction and at approximately 45 degrees, and eventually we shuttle the tendon in and we fix it in the tunnel, and we fix it with interfering screw. Now, I've told you about essentially 3 techniques using flexor lucis longus, peroneus brevis, and semitendinosus. Do they work? It's a legitimate question, and yes, they do. In 2018, with my group, we published our results on more than 60 patients operated using less invasive techniques, and it was an interesting study because we explained to the patients what was on offer, and they themselves decided what reconstruction they were going to have. So we were to some extent working as technicians. One of the things that we found out which surprised me, was that return to sport was faster and more complete in patients who were having peroneus brevis tendon transfer. We don't know why. We still have a question in this issue, but it is what it is. Science is like that. We can do the whole procedure endoscopically, and if you are handy with the arthroscope, you can do it. I've been using endoscopic techniques since probably 2000, 2001, but for this particular instance, we described a transfer, an endoscopic transfer of FHL, but essentially we have abandoned it because it takes too long. It requires too much fidgeting around, and quite frankly, I can do the operation much faster if I don't use the endoscope. Obviously, there are advantages, minimal soft tissue resection. The FHL transfer, which we described with Derek Loy, restores function without restoring anatomical continuity. And this is something that you have to tell the patient and you have to describe it very, very carefully in your informed consent, because a lot of the surgeons who are not familiar with these techniques will not understand that what we are trying to do is to restore function, not to restore continuity of the tendon. So make sure that you do that. This is what we do endoscopically. It is relatively fidgety because you don't drill a tunnel in the calcaneus, just pass the tendon in the distal stump, and then you bring it up so that it can come out of the proximal stump. There is a school of thought whereby you can do an endoscopic assisted free graft technique with semitendinosus transfer. This is very much in vogue in North America, where they use allografts, and it is possible, but again, it is fidgety, and in my hands I can use small incisions instead of small incision, one of about 4 centimeters, the other one of about 2.5 centimeters, and I can do the operation instead of using 6 or 7 incisions to put my arthroscope and so on. If you're undergoing, if you decide, however, to undertake this kind of surgery, make sure that you place your portals right, otherwise you'll end up in tragedy. There is preoperative portal placement that has to be strongly considered, and you have to plan it very carefully in advance. All the above-mentioned techniques can be securely performed. They're well described now. They are minimally invasive, they have a low morbidity, and they allow return to fringe sporting and daily activities within acceptable times. We have done a couple of systematic reviews as of late, and in 2023, and we have shown that by 6 months, essentially, if the operation has been performed well, most patients are able to return to sport. No technique is superior in terms of major outcomes and complications, and so it's impossible to draw any conclusion about the best management. However, I like autologous reconstruction because they allow me good clinical outcome, excellent functional results, and I have no allograft-related issues, including resorption of the grafts, which has been described, and massive infections that every so often ended up in amputation. I've dealt with a patient who had a xenograft of an equine tendon, and this was not performed in the UK, went abroad to have it, and he ended up with a real tragedy with many operations afterwards. So if you're going to use tendons not from the patients, don't use xenografts, just stick with allografts. Remember, however, that the end-to-end repair is possible by and large if the gap is less than 2.5 centimeters, and you can use reconstruction technique using local tissue or local free tendon grafts for larger defects. At this point, I thank you very much for your patience, and I very much welcome questions. Thank you.
Thank you, Mohamed. It's a really pleasure to see all this. We have a lot of questions, and we try to be a little louder.
Yes, okay. Okay, that's fine. Okay.
I have a question. Imagine that you have a patient with a chronic rupture, and it must be a rupture from 6 months ago.
Yeah.
Patient of approximately 60 years. What would you do?
Well, in general, I now use only minimal invasive techniques of the kind I showed you. And if there is a large gap at age 60, then I would strongly talk to him or her regarding either an FHL transfer, because at that age their athletic activities are not going to be that important, most likely, and I would talk about an FHL transfer or a free ipsilateral semitendinosus tendon transfer. The fact that they may have you talked about comorbidities.
It's a patient without comorbidities.
Okay, then now that's what I would do. However, in patients with comorbidities, for example, diabetes or hypertension and metabolic diseases and so on, I would still consider a reconstruction. But to minimize dissection, I would probably push a bit more towards FHL transfer.
We had this morning a discussion about releasing the muscle belly if you do a FHL transfer. Do you see the indication to release the muscle belly?
Do you mean releasing the fascia overlying the FHL?
Yeah.
Okay. Yes, you can do that. If you do it using minimal invasive techniques, remember that you are not going to see what you're cutting, and you may end up cutting some of the deep veins that are around there. If that happens, don't worry too much. Don't try and open it up. Don't try and make the incision larger to identify the veins. Just complete the operation. Do it. Close it all well, and don't worry.
Yeah.
In case of acute rupture,
yep.
do you have the same indication for general people and for athletes?
Yep. Allow me to correct. Allow me to understand. You want to know what I would do in acute ruptures?
Yes.
For athletes and non-athletes, correct?
Exactly.
Okay. Now, I've not opened an Achilles tendon, an acute rupture of the Achilles tendon, for more than 20 years now. And, well, from the beginning of the century, so it's 25 years. And I undertake a percutaneous repair, which we described with Mike Carmond in 2007, I think, but I've already been using it for several years. We now have some slight modifications in techniques. If you go onto the British Medical Bulletin, you will find a simplified way of undertaking the procedure, and it's done under local anesthetic. It takes literally a question of minutes. I just had yesterday the video of one of the British athletes who is a 1500 meter runner who last year in the World Championships in Glasgow, indoor championship in Glasgow, ended up rupturing his Achilles tendon. I operated on him straight away, and he did very well. One of these very, very serious guys who does everything he's been told without any problems. And he ran yesterday 3:57, not on the 1500, but on the mile. So it's not bad.
Okay. And you don't have an indication for a fascial transfer in case of acute
Prepare for athletes.
Sorry, I can't. Can you please repeat, please?
You don't have indication for a fascial transfer in case
Oh
of
gosh,
acute.
never, ever. I mean, the guys. There are some of my colleagues who undertake an open repair and they do a fascial turn-down flap. Okay. This has been shown in a very elegant randomized controlled trial performed in Sweden well before, probably some 30 years ago, to be of no benefit compared to simple end-to-end repair. So I cannot see why I should make an incision which is about 25 centimeters, turn down a flap, and then have a result which is not better than an open repair. Also, I do not undertake open repairs, so I just do percutaneous repair. We published a study, I think in 2022, where we tested two groups of patients. One in whom were undertaking just a percutaneous repair. The other one were undertaking the percutaneous repair and were augmenting it with FHL. Okay?
Okay, thank you very much.
No, I'm not finished. And and at 2 years, the FHL had a few points more on the ATRS score, but so it was enough to have it as statistically significant, but it was of no clinical relevance. So at present, we're trying to see these patients. We're trying to follow these patients up at the 5-year mark, because I don't think that there is any advantages in undertaking any augmentation in the acute setting.
Okay.
Now I finished this question.
Nicola, it's always great to see you. I just have a question. So you have an open Achilles, and you are treating also high professional athletes. So yeah. I'm assuming that the athlete you referred to was done percutaneous with your minimally.
Correct. It was under local anesthetic, percutaneous. With the patient awake, and above all, without an anesthetist, so you don't have to depend on the anesthetist.
Yes, and do you think that the post-op rehabilitation protocol would be different, especially if they're an athlete after percutaneous repair as opposed to any other technique?
Now, there is a great difference between what I described at the beginning of the century and what we do now. Some things have stayed the same, some things have changed. Paradoxically, my rehabilitation regime is now slower than it was a while ago. The patients are put in a below knee cast with the foot in plantar flexion. I leave the metatarsal heads free, so the patients are allowed to weight bear immediately. So they come out of theater weight bearing. They're under the local. And then at 3 weeks or at 2 weeks, depending on the logistics, I take off the plaster and I put them in essentially a liter cast walker with 5 wedges. And contrary to what I was doing earlier, where I was removing 1 wedge every second week, I now leave the wedges as they stand for the whole duration. The patients start active physiotherapy immediately after removal of the cast, and they undertake eversion and inversion of the angle against resistance, so they can use elastic bands and so on, and they do a lot of proprioception work under physiotherapy guidance. By 2 months, I see them after 1 month, and I see at that stage I try and ascertain whether they worked or not. I can see whether they worked, because if they really have had good physiotherapy input, the subtalar joint is mobile. If not, I take 1 wedge off and they start even more physiotherapy. at 2 months, by the time they are in 2 months in the ECAS boot, I then plan gradual removal of the boot over the course of 2 weeks. And so by essentially 3.5 months, they are out of plaster, and at that stage, I introduce a lot of eccentric exercise of the gastrocerebus complex, trying to avoid dorsiflexion. Remember that one of the reasons why we've done this is that a single molecule of collagen takes about 100 days to mature. So if you stimulate it too early, the tendon will elongate, and you don't want that. You want a tendon which is maybe a bit tight to start with, but then eventually it will loosen up. And if this is the case, then it will be a lovely tendon to work with. Normally, patients never complain because if they have a bit of loss of dorsiflexion, but they will always complain if they cannot push off. And if the tendon is elongated, they just are not able to push off.
But with this protocol, you have the patient in plantar flexion, not even reaching neutral for at least 10 weeks, if I got you correct.
Correct. And we have published this. It's published in Foot and Ankle International, either last year or 2 years ago, where we compared the classical regime to this we call it slow down rehabilitation. And it's only relatively slowed down because in reality, patients weight bear from day one. They undertake, when the plaster comes off and they go in the boot, they do undertake a lot of physiotherapy under physiotherapy guidance, where they stay out of the boot and they undertake a lot of exercises with the physiotherapist. So they are not standing still. It is not a nihilistic approach at all.
We had today some talks about functional therapy. There was a colleague, he's using a boot where only plantar flexion is allowed. So he blocks dorsiflexion. And would you see the benefit for the tendon to get a little bit motion?
I mean, this is what. Yeah. This is we've done that as well. We've gone through all these things for the as you know, Achilles tendon is one of my pet subjects, and so we've gone through all these things for the past since 1996, since I became a consultant. And yes, what you can do is to have a front slab, okay, with Velcro straps, with the ankle in plantar flexion, and you can do plantar flexion, eversion, and inversion against resistance. Works beautifully well. Only patients cannot walk as well as in a ECAS boot.
Dr. Maffulli, I have a question.
Yes.
What is the main difference between your technique and the Dresden technique in terms of
the Dresden
outcomes and rehabilitation?
Okay, the Dresden, one of my good friends, Dr. Wagner from Chile, has done a lot of work with the Dresden technique. To my knowledge, there is no clinical difference between any of the minimal invasive techniques. I like the fact that the percutaneous technique I use only requires the use of a large Mayo needle, 9 centimeter Mayo needle. The Dresden technique obviously needs the Dresden device. Sure.
Okay. Today we also heard a very nice talk from Switzerland. Lucas was telling us that he would prefer to do 3 bundles.
I'm sorry, I was coughing and I couldn't hear you.
We're sorry to hear you, and we appreciate that you are accommodating us, even though you're not in the best.
Don't worry.
I guess.
Don't worry. What did you do this morning?
Lucas from Switzerland was doing high-level athletes. He was doing them open, and he kind of pointed out that he's doing a 3-bundle repair, and he says that the soleus is very important in the repair. and in the return of function because of the orientation of the muscle fibers and the way that the athletes need to perform. What is your counterpoint, if you will, to that, using your percutaneous technique? Or what do you think are the pros and cons?
I don't have a counterpoint there, because part of evidence-based medicine is not just level 1 studies, it's also able to audit what you've done and see how things go. I would not undertake a 3-bundle technique because it's very invasive. And to my knowledge, there is no evidence of any advantages compared to simpler, faster percutaneous techniques.
Professor Maffulli, it's still an honor, and everybody is able to watch this later. Everything is recorded, and we will.
Okay. Well, may I put forward an idea?
Yeah, sure.
You've managed to get together an enormous amount of people with a great interest and expertise in the Achilles tendon, and I think that we should try and get together and produce something like a position statement or something like that.
This was our hope to do this, and we have some questions. We will try to answer this tomorrow at the end on the conference, and we will send it out to the speaker, and we'll ask for their opinion. So thank you for this, and we will be grateful if you participate also in this.
Okay. Well, I will not be able to be online tomorrow, but send me whatever you wish, and I'll be happy to take part.
Thank you. It's a great honor to have you with us.
Have a good night. Thank you very much.
All the best.
Sorry. Have a good night. Have a good night. Have a good night. Bye-bye.
Bye. Bye. So now we're switching over to Karsten Knobloch. He's also from Hanover, and also, I think, Karsten, you're also in Vienna. And during the day, we had a lot of talks, and always this coming over this point shockwave. So, Karsten, good to see you. Good to see you. Are you Hanover or in Vienna? Where are you now?
I am actually in Hanover, Kirchrode, but there is an image from Austria. So as Nico is commuting in between Rome and UK, I'm commuting in between Austria and Germany, but now I'm in Kirchrode, nearby Anna Stift, where you have been working quite so long, and it is a distinct pleasure. And in fact, I thought I was the opening act for Nick Maffulli. However, you know, reality bias and things change in a disruptive way.
So who will be able to talk after Nicola Maffulli than you? Who is more better? So we're really grateful that you accepted this change and waited, and we are looking forward to your pre-recorded talk, and then we will discuss it definitely afterward with you. Thank you, Karsten.
Yes. Good evening, ladies and gentlemen, dear Achilles tendon friends. My name is Karsten Knobloch from Germany, and I'm highly delighted to talk about my most beloved tendon, the Achilles tendon. So I'll start with my conflicts of interest. So in my practice in Hanover, I'm starting usually with a risk factor analysis. I will give you some more arguments scientific-wise later on this, followed by multiparametric ultrasound, leading to an individualized, tailored treatment for your given patient. In risk factor analysis, I'm looking on load, on medication, on blood levels of cholesterol and urea, and even on genetics. You are aware that overloading is a big issue, and it's known for running athletes that you can increase your mileage per week by mainly 10%. If you increase faster, say 15, 20, 30%, you will end up most likely with some overuse injuries, such as the Achilles tendon. We are aware that there are some medications which can be detrimental for your Achilles tendon health. There is cortisone, quinolone antibiotics, aromatase inhibitors, and statins for lowering cholesterol, especially in combination of, say, quinolone and cortisone in medication in patients aged 60 or older. You can see that the adjusted rate difference is nearly 7 out of 10,000. So this is a patient group of special risk for Achilles tendon problems. It is known that ibuprofen and other non-steroidal anti-rheumatic drugs can have detrimental effects on the turnover of the tendon and therefore limit the tenocyte division. Recent reports highlight that maybe even for bisphosphonates, there might be dose-wise problems with higher frequencies of tendinopathies, especially alendronate is showing the highest association of an odds ratio of 16 in contrast to other osteoporosis medications. Jill Cook and colleagues showed beautifully in a meta-analysis that higher cholesterol is adjacent to higher Achilles tendon risk. This is true for lower HDL and higher LDL cholesterol levels as well. So the worse your cholesterol levels, the worse potentially your Achilles tendon. Bernie Segesser, the founder of the Rennbahn Clinic in Switzerland, always told me that he applied allopurinol to influence the urea levels, especially in Achilles tendon patient. And he is still true because science is supporting the correlation. So in a way, metabolic risk factors, cardiovascular-wise, may worsen tendon health, as shown by Karin Silbernagel just this year in the Journal of Orthopedic Research. A novel observation is, and I would say the jury is still out there, that especially in the NFL, the risk for or the frequency of Achilles tendon ruptures is especially during and after COVID times significantly increasing. It is unclear what the mechanism is, but it is an observation. As you can see, quarterback Aaron Rodgers, when traded on his first game in September for the Jets, he suffered in this situation Achilles tendon rupture, and Kirk Cousins, at that point of time, the quarterback of the Minnesota Vikings, suffered the very same injury on November 1st in 2023. Genetic profiling is an option. Martin Schwenus from Pretoria, Southern Africa, has shown beautifully that on the long arm of chromosome 9, there might be mutations, and these can be commercially analyzed by kits like this one from United Kingdom, which I did on my own. And DNA Fit showed that my genetic injury predisposition is pretty high, as you can see, in contrast to other patients or athletes. And you can see my personal genotype in terms of the collagen 1AA and collagen 5A1 locus with my genotype, which might have a detrimental effects on my personal Achilles tendon health as well. As far as imaging is concerned, we not only look on the intrinsic tenocyte part, but also on the vascular, on the nerval, and the immune system as an extrinsic compartment. Back in 2002, this is from the British Journal of Sports Medicine, and you see two images on the long axis, on the left hand, on the short axis, on the right hand of ultrasound, published by Amol Saxena, who will speak later this evening at 10 a.m., and Nick Maffulli, who will speak just after me, after the break, and showing you how 23 years ago ultrasound resolution was. And I'm very delighted and honored that Nick is just around the corner after my talk. So please tune in to see Nick's view on the Achilles tendon. It is clear that the anatomy based on modern ultrasound analysis is more complex than we thought. So you see, there might be variations both for the insertion of the soleus and for the gastrocnemius, as you can see in this analysis. And I'm happy that Ine Müller just yesterday provided me with her PhD awarded paper published in the British Journal, highlighting and emphasizing again the role of the triceps surae muscle tendon unit during rehabilitation. In ultrasound, we can now apply, and this is my machine, a Canon Aplio E800 in grayscale in insertional Achilles tendinopathy, as you can see in the left upper panel. Then you can apply power Doppler ultrasound. You can apply advanced dynamic flow, and now you can even apply superb microvascular imaging. So this is specialized and ultra high resolution Doppler modes to elicit and to create an idea of the vascular architecture of the neoinflammation. And this is shown on the long axis. You can see it on the short axis as well. So you can see the vessels entering more lateral, more medial from the carga fat pad into the tendon. And this helps you quite a lot when you try to do ultrasound-guided injection techniques, for example, which I will refer on later. You can now even measure and quantify vascularization. So the SMI allows to create the vascular index as a region of interest. So in this case, it is 10% vascular index, and this can be done before and after each treatment, what you do. And so you can see and follow the course of the of your patient. My tendon career started with this very little study using a microcirculatory tendon mapping system called Oxygen 2C, and we could show that at the point of pain in mid-portion Achilles tendinopathy, we had significantly higher laser Doppler flowmetry values than in the asymptomatic contralateral side, as you can see here. And this was published in the American Journal at that point of time in 2006. And Anja Hirschmüller has shown beautifully when she was still in Freiburg in southern Germany with Norbert Südkamp that among marathon runners who want to run the Freiburg Marathon 1 year later, the presence of neovascularization in asymptomatic patient or in asymptomatic runners is a predictive factor for the development of Achilles tendinopathy. So the odds ratio over the 1 year of marathon training was 7 among these running athletes. And this is supported by paper, a very recent paper. I just received it yesterday by Daniel Kuschmann, showing that pre-screening with ultrasound in an athletic cohort at the beginning of the season can really help you quite a lot in identifying athletes at risk for patellar tendon, especially for the Achilles and for the plantar fascia, as you can see with the relative ratios. So very, very good and solid paper just published in the British Journal recently. As far as ultrasound is concerned, we can even apply elastography, and we differentiate strain elastography, which is only semi-quantitative and has, in my view, no scientific argument in this very moment, while shear wave elastography is quantifying stiffness, which is user independent. These machines cost much more because it's much more complex to build. And I show you the history of the short history of shear wave elastography, one paper by Karin Silbernagel and colleagues in 2015. This is 2017. You see even better resolution and the values displayed in kilopascal. And now with the modern shear wave elastography mechanisms, you can now assess in all these fields the elasticity or the stiffness, which is displayed as an average plus the standard deviation. And the smaller the standard deviation is, say less than 10%, for example, the more credible are your values. So this adds up much more information on your tendon health. So we do ultrasound grayscale diameter measurements We do SMI, superb microvascular imaging, for the degree of vascularization, and shear wave elastography to measure the stiffness in a multi-parametric view. And Jill Cook and colleagues just recently shown an interesting outview that maybe even artificial intelligence might help in the future in providing a roadmap for ultrasound assessment in your Achilles tendons. So as far as treatment is concerned, the question is how to accelerate healing. And my idea is to best heal even faster. And on the last year's German foot meeting, DAF in Vienna, I had the pleasure to lead with Kiriakos Daniilidis, who has spoken this afternoon already in this very event, the concept of the regenerative clockwork. The idea is that you combine different measures. So in tendons, you can combine radial and focused shockwave, low-level laser therapy, oscillating magnetic fields, plus different injection techniques, hyaluronic acids, PRP, polylocanol, maybe exosomes or collagen. And do not forget to optimize loading, to apply eccentric, most likely even proprioceptive work and kinesiotaping. And then this is the framework I'm now considering for precision and coordination, because in my view, it plays quite a role in what sequence the different tools are applied to the best of our patients. Load optimization, this is Karin Silbernagel, is very important, and I often or usually apply this pain monitoring model, meaning that patients are allowed to load their tendons to a visual analog scale level of 5 out of 10, usually with good results. Eccentric training in combination with concentric training with the appropriate dosage is important. Håkon Alfredsson from Romeo has shown beautifully that in the moment you have the lower position on the stair, the blood flow will somehow diminish. We could show nearly 19 years ago that if you do 2 or 3 months of daily painful eccentric training, the blood flow will be reduced by 50%. We interestingly found that females suffering from Achilles tendinopathy doing the very same dosage of eccentric training do not respond as good as males to this exercise regimen because microcirculatory changes are evident amongst gender as well. And when I met Jill on a very cozy evening in Auckland on the ISMST Shockwave World Meeting, we came in a dinner talk to the idea that for mid-portion Achilles tendinopathy, the decline under 0 degree is important, and the concentric components, so eccentric and concentric, while on insertional, because you create in Kagas fat pad in kind of impingement, it is good that the eccentric should stay to the level and do not do the decline more negative. And the concentrics are much more important. So depending on the location of your Achilles tendinopathy, insertional or mid-portion, one should modify stairs, yes or no, in our view. I'd even apply or combine it with, for example, vibration work on a power plate, where you really can load to a much different degree. And it is known, just recently published, that patients with painful Achilles tendinopathy usually try with some compensation strategies when doing these exercises. So it's very, very important to closely or supervise or even use mirrors or something to have appropriate exercise regimen. And the brain may play a role in this regard as well. It's known already 10 years that kinesiophobia may be linked with less good outcomes in Achilles tendinopathy. And just recent reports show that there is a link in between anxiety, depression, fear of movement, and fear of Achilles tendon rupture in a number of patients. So the brain plays a very integral part in this view. And as this is an innovations talk, I will show you the HALO system. And the HALO system is a measure to stimulate the motor cortex, like deep brain stimulation. And the mechanism is called neuropriming. And this technique helps the brain to enter a state of heightened plasticity. And this is termed hyperplasticity. And during this period, which is 30 minutes, for example, the brain adapts to the training much, much more effectively. You might combine eccentric training, maybe on the power plate, even with neuropriming. So you have deep brain stimulation during your exercise. And a future additional way is that maybe even shockwave play a role on the brain. We have a CE certified machine, MRI navigated electromagnetic shockwave, where we do focus shockwave on distinct areas of the brain. And there's a recent report from Vienna showing in healthy volunteers stimulated to a distinct motor region in the brain by focus shockwave, that behavioral tasks, so motor learning, can be substantially improved with the help of focus shockwave in these tiny areas of the brain. So this is what I foresee for the future. There is even reports besides the eccentric for proprioception, and an ankle or a reduced ankle proprioception is just recently shown linked with Achilles tendinopathy, and this has been shown a clinical 10 years ago already, or 15 years ago, when we analyzed the proprioceptive training for female squad of Bayern Munich, and could show a significant reduction over 3 seasons for Achilles tendinopathy when doing proprioceptive work. So besides the eccentrics and concentrics, it is worth to consider proprioceptive training as well. Medical flossing, or in the US, voodoo flossing, might be an option as well, where you can combine your eccentrics and concentrics with a tourniquet, which apply as well. And this might help quite tremendously in reducing the blood flow. And you see, this is my own mid-portion Achilles tendinopathy in 2016, when I was still marathon running. So I had some 9 to 10 millimeters AP diameter. You see my neovessels. And immediately after 3 minutes of flossing, as you can see here, 4 minutes later, this neovascularization was significantly reduced. So a similar effect, which I usually see with polydocanol injection, but this is needle-free, only by tourniquet. So there is no hyperemia after. And this leads the way to even combining compression and cryotherapy. And when I was young, as you see, we did study on the AirCast cryocuff, where you have compression and cryotherapy, and measured microcirculation of the Achilles tendon. And you see the main effects within the first 10 minutes of cooling. And then there was less extent of reduction of the microcirculatory blood flow. We then had the idea to do, like in cardiac surgery, ischemia and reperfusion, 3 sets of 10 minutes cryocuff, showing a superior change in Achilles tendon microcirculation. And this holds true for the cryocuff. And we did the very same with the cold blue, different cooling device, as you can see, published in the British Journal as well. So this intermittent cooling and compression therapy appears to be pretty good. And this led to the idea of the PRICE system. And in nowadays, it's not only PRICE, but also peace and love. Very, very easy to memorize: protection, elevation, avoid, please, anti-inflammatory drugs. I showed you before, ibuprofen, compression and education, plus load optimization, optimism, vascularization, and exercise. Please apply peace and love. There is an interesting study published, I think, in 2002 by Paoloni and colleagues from Australia, showing that topical NO could significantly reduce pain after 3 and 6 months, as you can see here. They did a long-term follow-up up to 42 months, still showing that the GTN topically applied was pretty successful. And we did microcirculatory assessment, showing that there are no changes in the, let's say, capillary blood flow but we see a facilitated venous outflow post-capillary. So there seems to be some changes of the GTN, which are beneficial for collagen turnover. So this might be an option. And recent data shown for curcumin in osteoarthritis, showing a very strong interaction with matrix metalloproteinases. And this is very important in tendinopathies, as you might know as well. So I foresee that curcumin and other phyto medications might play a, let's say, evolving role in the treatment of tendinopathies. Energy-based therapies involve shock waves, laser, magnetic fields, and vibration. And in shock waves, we differentiate radial pressure waves, which act like an air gun, and focus shock wave with different generators. And it's very important to stress out in this moment, the treatment parameters really matter. So you might have an appropriate machine with wrong parameters, you will end up with not that good results. There are substantial differences physical-wise in between radial and focus shock wave. You see here an animation of how an electromagnetic focus shock wave is traveling through tissue up to 8 centimeters tissue depth. So you see the shape of the shock wave is changing by depth. As far as, let's say, energy levels are concerned, depending on your target tissue, you might end up with different energy flux densities, so energy levels, which is very, very important. So if you deal, for example, with a more insertional Achilles tendinopathy, where you might end up with some bone edema as well, you might have high energy, say higher than 0.25 millijoule. If it's only the mid portion where the issue is, you might apply medium energetic shockwave. If you try to change nerves, for example, you only need very nano energetic. So depending on your target tissue, even your energy flux densities must be different, and shockwaves are mediated by a mechanism called mechanotransduction in a protein response. It is recently shown and awarded with the Nobel Prize that there are mechanoreceptors called piezo1 and piezo2, and this was awarded in 2021 to Lebanese colleague Adem Patapoulian for the discovery of mechanoreceptors. We are aware that focus shockwave have a myriad of, or plethora of effects. So it's shown that focus shockwave can stimulate stem cells. It's shown already in 2005 that there might be, depending on the energy levels and depending on the numbers of shots, as you see, 500,000, 1,000, 1,500 with nano or medium energetic focus shockwave, you might have an anti-inflammatory effect as well, depending on NOS modulation. It has been recently shown that shockwave can stimulate exosomes, and exosomes are very important for the intercell communication. And the World Society for Shockwaves, the ISMST, has proposed indications depending on your shockwave experience. So beginner, advanced, expert, and experimental indications. They are listed on the ismst.com homepage, and Achilles tendinopathy is, as plantar fasciitis, patellar tendinopathy, a beginner standard indication, because evidence-based wise, we have more than 100 papers showing that both radial and focus shockwave are quite good. A good read is Vasilos Korakakis' paper published in 2018 in the British Journal. And the most recent comprehensive paper dealing with shockwaves in athletes is published by Adam Temfody, who will speak after Amr Saxena tonight, 10 p.m. German time. As well. So a very, very good read, British Journal of Sports Medicine, just published. And I mentioned Amol. Amol was the first user in the US doing the FDA trials for shockwave, and he showed beautifully that the combination radial and focused is even better than radial or focused alone. So he will tune in later, and we will have, if you are around Boston in the beginning of March, we will celebrate the birth of the American Society for Medical Shockwave Treatment, ASMST, and Adam and Amol, as well as Karin Silbernagel, will be around. So my current best Shockwave parameters, radial-wise, 0.8 to 1.5 bar, 8 hertz, so rather slow, 2000 shots with a C15 ceramic applicator. In focused electromagnetic, I'm using in between 0.07 to 0.15 millijoule, 4 to 5 hertz, 2000 shots with a standoff number 2. It's known in the studies and derived from meta-analyses that you can expect some 10 points VISA-R improvement. It is shown by Nick and Jan Dirk that eccentric plus radial pressure waves are better than eccentric training alone, published in the American Journal. And this is work in progress. Even elasticity can be substantially and fast improved by 26 kilopascal to 10 kilopascal immediate after a combined focused and radial session. And there is even an observation just shared and published or presented by my friend Martin Ringeisen for the first time in 2022 on the DIF meeting, that in a patient who had underwent already 2 Achilles tendon ruptures with a fatty degeneration of his tendon, and he requested for pain 5 sessions of focused shockwave, the fat architecture changed after 5 months. After 3 years, you see a change in the MRI quite tremendously. So this is much different to what it looked 2.5 years before. So this is clinical cell reprogramming. So fat cells, via the mechanism, exosomes, toll-like receptor 3 activation, epigenetic plasticity, can help in clinical transdifferentiation of tissues. So fat cell into a tendon cell. It takes long, but it's obviously happening. Low-level laser therapy is helping quite a lot, even in tendons, by photobiomodulation. And I'm currently combining 808 and 904 nanometer lasers as class 3B devices. There are some randomized controlled trials suggesting that combination of low-level laser and eccentric training are quite good idea. There are laser data showing that the penetration of these 2 wavelengths is a bit different, but both are beneficial and pain-free. Oscillating magnetic fields are an evolving field, even for the Achilles tendon. We differentiate PEMF, pulse electromagnetic fields on the one hand, and electromagnetic transduction therapy machines on the other hand, depending on effective transduction power, as you can see here, and depending on speed. So EMTT is some 40 times faster than a PEMF. It is supercharging your tissue, and it's known that, for example, on the cellular level, there are different membrane potentials relevant in each and every part of your cell. And you might even, by changing the membrane potential, changing the macrophages from an M1 to an M2 response. And you might even change proliferating to non-proliferating cells depending on your membrane potential. We have shown that VEGF is stimulated by EMTT quite tremendously, and even clinical-wise, Amoy Saxena and Ludger Gerdes-Meyer have shown in a very initial report that EMTT is, when combined with a standard treatment in Achilles tendinopathy, can further help pain reducing. And it seems, if you apply EMTT alone, again, that elasticity is beneficially influenced by EMTT as well. As I come to injections, Lars Öberg and Håkon Alfredsson were the first in 2002 to show an extratendinous sclerosing therapy with polydocanol. He could show a remodeling over 2 years if you apply it extratendinously under ultrasound control. And this is what is now possible. So you see before and after SMI 10 or 11% vascularization, and immediate after an extratendinous polydocanol sclerosing, a significant reduction. You see this patient who already had shockwaves and PRP beforehand with a 11 millimeter diameter and very, very high stiffness. And the combination of polydocanol and tromel extratendinously, as you can see here, that's why I need to know where the vessels are, so I can directly hit the feeding vessel quite tremendously, and you see substantial effect even 6 days after. So this is an option. Hyaluronic acid is another option. There is a very recent report showing that both hyaluronic acid and collagen might be quite good for your tendon health in terms of changing inflammation. I apply hyaluronic acid in the same fashion as polydocanol extratendinously, as you can see here, before and after with a 24 matrix probe. You can see here, even in insertional issues with a substantial inflammation, I'm coming in the Karga fat pad. As you now see, this is my needle tip in the Karga fat tip, in the fat pad, and then injecting slowly and gradually. You will see over 20 seconds that by beat, the vascularization is reduced. Now I'm injecting again a small portion, checking again, readjusting my needle tip, then syringe again, then readjusting, and you see a significant immediate response of the inflammation in the insertion of the Achilles tendon. You see before and after quite tremendously effects. Injection location matters. In the Achilles tendon, you are aware of the suralis nerve on the lateral side, so please inject from the medial side. If you inject from the lateral side, you might harm the sural nerve. And there is even a very interesting report that the hyaluronic acid and shockwave may play good role together, published in PLOS ONE, because shockwave is inducing CD44 receptor, and this is the main receptor for hyaluronic acid. So if you want to apply hyaluronic acid either for tendinopathies or for osteoarthritis, it is quite good to apply focus shockwave maybe a week before to have some CD44 induction. And if you have more CD44 receptors, more hyaluronic receptors, then you might end up with much more effect of your hyaluronic acid injection. So again, coming to the end, in my view, the regenerative clockwork, precision and coordination is helping your patients and your painful Achilles tendon. Thank you so much for attention, invitation, and your friendship.
Karsten, thank you. Thank you.
My pleasure.
Really, okay, where we should start. There was so much in... maybe we can start. We discussed some points and then we said, okay, we keep this question for later if Karsten is with us. So this is the first question, especially after surgery, then you have the cast, you start functional therapy, and after 5-6 weeks, you feel the tendon, the Achilles tendon, as after a suture, is a bit more stiff. What would you add on? Would you go with shockwave or would you go with flossing? What is your thing? Because you're not able to do stretching. That's not good. So we need something else. What is your advice?
So in my view, based on my observations and what I interpret from science, is that both shockwaves and these oscillating fields, which are analyzed with elastography measurements, can significantly reduce stiffness. So in my view, I would start even not, let's say, wait for 4 weeks or something, but immediately after operation to apply additional therapies, say shockwaves and magnetic fields. You might, if pain is tolerated, add on the flossing, because the idea of the flossing in the US when it came into practice was to increase range of motion and decrease adhesions. And that's why voodoo flossing in the US, say 10, 15 years ago, started to over joints like the S-March bandage to increase range of motion. But I think physical-wise, we have much stronger effects with these energy-based therapies. So shockwaves and the magnetic fields appear to significantly, by numbers, reduce elasticity or improve elasticity and reduce stiffness by 50% after one session only. So I think the earlier you are, and as you might remember, Nick said, I have a history as a plastic surgeon as well, and not doing any flap surgery anymore. So no worries. But I know how wounds and scars are creating. It is let's say a cascade of mechanisms. And the sooner you are interfering with this cascade, the better your scar is. And the sooner you apply shockwaves and EMTT after any operation, whether it's direct suture or FHL or whatever things, I think this might really reduce, on the one hand, complications and improve function.
Thank you. Question from you?
Yeah,
found with the genetics?
Yes, Karsten, thank you for the wonderful descriptive talk. I noticed the part about the DNA fit, and it was very interesting for me. Genetically, you might be predisposed to a certain injury, and I know this is a general comment or maybe a question, but why is it still, even in the even though Achilles tendon injuries are so very common, we do not have an ACL preventive therapy like we have for the knee ACL. It's even FIFA approved before. Right. But we are still lacking that, and I noticed you've done a lot of work with Karen Sibyl-Nagel, and I also posed that question to her, so I'm posing it also to you.
Very, very good question. On the one hand, let's say privacy. I have 4 uncles. 4 of them, all of them were non-sportsmen, had an Achilles tendon rupture. Only my father, who was a sport teacher, had no Achilles tendon problem. And I myself suffered Achilles midportion tendinopathy being 34. So, and then I did my DNA testing and saw, my genes are not so good, on the one hand. And I'm fully with you because in the past, as you saw, the Bayern Munich talk we did on proprioceptive training just because before the World Cup 2006. And 2 of the FIFA medical commissioners visited Hanover because we implemented a, let's say, comprehensive proprioceptive training for soccers. And still, for me, it's hard why, for example, the eccentrics and the proprioceptive training, like we have in FIFA 11 for ACL, have not found the way into professional sports and recreational sports. Yes, because it's so cost effective. It is. On the other hand, it is quite hard, as when I was still in university, doing a lot of studies to prove that, for example, eccentric training or eccentric and concentric, whatever, might have a protective effect over, say, 10 years. Because as you can imagine, if we do eccentrics for, say, a year, and we want to show that there is a reduced risk, we need long decades, so at least 10 years, and then loss of follow-up and so on. It's a big tricky. So I believe that it is very hard to perform a preventive, say, eccentric training trial. However, maybe this stage, and Nicola has proposed a consensus statement, and maybe even we might pose some future scientific questions, because there are a lot of people, and I wrote a lot on Achilles. Nick wrote 5 times the fold what I wrote, but there is still so much question. So this might be, an idea to motivate our youngsters and our young stars to go in this direction. So this might be a very cost-effective way, a combination of eccentrics and proprioceptive just for Achilles tendons. Absolutely agree.
Karsten, thank you. We are right on time. It's Valentine's evening. Enjoy the evening, you told me. Greetings, and we will see us soon. Thank you for your talk. It was great.
Thank you very much, guys. Bye-bye. Have a nice Valentine's.
Thank you. Thank you. So we have time for one case discussion, and then afterward we'll go to break. Just a short message for the people, especially from Brazil. There will be a LATAM course from MIFAS. Take care of this, and after the break we will be with Brazil, so it's a good time. So could we show the first case? Yeah, click it. So this is a young lady. She came in with a fixed plantar flexion, and as you recognize, she was treated with shoes. They tried to get the fixed plantar flexion on the other side. So we can discuss this. This is what I thought also. Could we click to the next picture, please? This is how she is able to put strength on it. Okay? So it's the left side, it's fixed. So stop, and now we discuss what we can do. Nasef, I think you know the case, maybe?
Yes.
You know the case, so you're not able to.
Is there a leg length difference?
No.
What is the cause of this?
Maybe you could go one slide further, please, to the presentation. One slide further. There we have the MRI. So she had an accident. You see the gastrocnemius head. It's atrophic and it's contracted.
You can see it clinically. Go back to the clinical pictures.
Clinically, you see this
Even
also.
standing.
So what can we do? What's the option?
Is there still some activity for plantar flexion?
Yeah.
An active plantar flexion.
She had an active plantar flexion, but she starts by 20 degrees, but she has power.
So there is no reduction with the flexion of the knee?
No, it was
it's
straight.
fixed.
It's just isolated necrosis.
How many degrees? They have a silver scroll test.
You see more than 20, no?
More than 20. It's fixed. You cannot
It's
go.
equinus.
Yeah,
It's
equinus. It's equinus, but a good power.
Okay.
She's sporty, active.
And does she has any complaints?
Yeah, because she's not able to walk plenty great with both feet. This was the reason why the colleagues put here 2 shoes on it.
The MRI of the distal part is normal.
It's perfect.
Yes.
Yeah. The distal part is perfect. Any suggestions?
Where exactly is that image actual? Where exactly is that?
This is, you see the gastrocnemius, you see this is.
I would consider a lengthening procedure.
Yeah, this is the question. Lengthening is clear.
Yes, that's the question.
I would do strayer.
Do you think you can stray with the strayer so much?
I will go
Not enough
proximal.
efficient. Percutaneous tendon.
But that's why my question, because if you're, where are you? If a gastro will
Not working. Gastro is, I don't think so.
I don't know.
But you have to be. You have
Have
to
you
be
tried
distal.
electromyogram superficial? Let's see the activity of the muscle.
Activity like this. On the one side, it's working, on the other not.
With the strayer, you will gain 10 to 15 degrees.
In such a contract situation, it's not, silver skirt is not working. There's no beneficial, if you do a silver skirt or not, there's no.
Why not a gastro? Because it's very proximal. And these might be distal to the release.
But this is less effective than a strayer.
But just the fascial release, you think the fascial release work on this contracted?
No, but if you think about just the levels of lengthening, so is below the lesion, I'm thinking about proximal.
Percutaneous tendon.
You would go for the tendon. Tendon is fine.
Yeah,
it works.
Yeah,
We are discussing the level.
We are discussing the level.
It's distal.
And
For me,
she's
it's
not
proximal
coming
to the
from,
lesion.
so she's not coming from habitual tiptoes. I missed the.
She's walking on tip. She's no hip
She has a fixed.
No. She had an accident by I think 6, 7 years
Not
ago.
really fixed. He has no, maybe he stopped. She stops.
Yeah, she stops.
But it's not rigid.
It's not fixed. No. And she had a good power. She can stand.
It's
I would
not a
go
nervous.
for a strayer. If you go more distal, you lose power. If you go more proximal, you will be less effective.
So it's because of the time we go further. I will show you what I did. Next picture, please. I did this. I did it totally open. Why? Yeah. VY. Because I thought isolated gastro is not enough. And you see how much I needed for her.
Yeah, but still you can try that and see what happens. Even in the OR.
Yeah, we try.
Do a gastro and then.
Maybe the next picture, please. And this is in the OR. And what I add on was a dorsal capsule release distal.
What is the 20 centimeter wound for a VY? No, it's not a joke. It's a question.
Yeah, this is what I thought I needed. This amount.
10 centimeters.
Yeah. We gained at least 6 centimeters, I think. And I was happy to do it at that area because it's good blood, good supply. I was and the tendon we didn't touch the tendon.
She's a young
lady. The next one, please. This is 10 weeks post-op. Plenty great. You see, I did a release proximal also. to gastric head.
Please you have sharks swimming in your
Come on. Next one, and now you see the functional result. She has power. Oh yeah.
Sorry, because you have.
And the next one, please. Last. And this is what I like. This is 10 weeks post-op. She's able to walk plantigrade. And fun fact of this, could you go to the next one? We met 7 years later, and maybe the video is working. We lost a calf, yeah, but it's the muscle, but it's still there. So if you go to the tendon, you may be in risk that you're shortening again. Okay, thanks.
It's funny, the degeneration is still continuing.
And now we're going to the break. We see everybody back, and local time here, Munich time, 8:30.
50 minutes.
In 50 minutes, and then we will go on with Brazil. It's really exciting. You stay tuned. Brazil is really exciting talks.